My name is James Roberts. I'm board certified in internal medicine and cardiology, and this is the first section of DVD 2 in our presentation, Immune Mechanisms in Cardiovascular Disease. This section deals with cardiomyopathy, heavy metals, and heart failure. This is a normal heart. This is the peristernal long axis view. This is the front wall, this is the back wall, the mitral valve, the aortic valve that allows blood to leave the heart. This is a peristernal short axis view, kind of a slice of bread view. You can see that the walls of the heart are smooth and symmetric. This is the apical four-chamber view, the left ventricle, the right ventricle, the left atrium, the right atrium. All of the walls of the heart are thickening and moving inward in a uniform and appropriate fashion with a normal ejection fraction of 50%. This is a patient with dilated cardiomyopathy. The heart is enlarged. There is diffuse hypokinesis. None of the walls are moving in normally. The mitral leaflets are not acting normal, so you have mitral or you might have tricuspid regurgitation. This is the echo of a patient with dilated cardiomyopathy. Cardiomyopathy is one cause of congestive heart failure. Congestive heart failure refers to any condition that is compromising the heart's performance such that flow of oxygenated blood is insufficient to meet the needs of the cell of the body. If you lose heart cells with a heart attack, if the heart is under strain due to valve disease or due to an arrhythmia or due to a cardiomyopathy, you can have congestive heart failure. Now, in cardiomyopathy, the problem isn't a valve, the rhythm, or a heart attack. It is a metabolic problem of the heart muscle cell called the myocyte. It's having trouble generating energy. It doesn't perform well. The heart becomes stiff. It doesn't feel well. We call this diastolic dysfunction. Later, it's unable to generate contractile force. The ejection fraction falls. That is called systolic dysfunction. When heart failure occurs due to cardiomyopathy or any other cause, there is a neuroendocrine outpouring. When the autonomic nervous system, the kidneys, or the adrenal gland sense insufficient forward flow, they release hormones that whip the heart. This is a maladaptive response designed to increase survival of cave people. Consider what are the situations in which blood flow to the internal organs would be compromised in a cave person. Well, dehydration, electrolyte deficiency, hemorrhage. So the normal response of insufficient blood flow for a caveman would be for the autonomic nervous system to release adrenaline and noradrenaline to constrict the blood vessels and preserve blood flow, and to whip the heart, increase the heart rate, increase contractility. It would make sense for the kidney and the adrenal gland to release hormones that cause the body to retain sodium and water. That would make a lot of sense if you're bleeding to death after being mauled by a saber-toothed tiger. Those were the diseases, the conditions of prehistoric man for which we were designed to function. Now, heart failure is a brand new situation. It's only been around for a couple hundred years. Our body is not caught on. So when the kidneys and the adrenal glands and the autonomic nervous system experience reduced forward blood flow, these whips that will, in the short term, increase cardiac performance damage the heart. If we constrict the blood vessels, that makes it more difficult for the heart to pump forward. If we retain sodium and water, we get congestive heart failure. If we whip the heart with adrenaline, we're going to kill the cells. So the body's response to heart failure is really what kills the heart. Now, the body's response to heart failure is as if there is an infection, because one of the causes of low blood pressure and low organ perfusion in prehistoric man would be infection. We had a lot of infections back then. So when blood flow is compromised, the body responds by upregulating the immune system, and Th1 and Th17 inflammatory mediators, the same culprits in atherosclerosis, are elaborated. How do we treat heart failure? Because when this happens, when these immune and metabolic whips are placed on the heart, the cells begin to die. They commit suicide. It's called apoptosis. The valves become leaky. We get cardiac arrhythmias, congestive heart failure, and death. Doesn't matter what the cause is, the body and the immune system are going to finish off the heart unless we intervene. How do we intervene? Well, we can give you water pills, diuretics, vasodilators to dilate your arteries. It's easy for the heart to pump forward, drugs to stimulate the heart. Modern heart failure therapy is neuroendocrine blockade. We're going to block the adrenergic nervous system with beta blockers. We're going to block the renin, angiotensin, aldosterone system with blockers of those hormones. Nutritionally oriented doctors will give you antioxidants to block generation of free radicals. We will give you coenzyme Q-carnitine and ribose to support the mitochondria. We'll give you anabolic support such as testosterone. We can put in a biventricular pacemaker to give your heart a mechanical advantage, a defibrillator to prevent you from a lethal arrhythmia, and we can use external counterpulsation, which we'll talk about later, magnetic molecular energizer therapy. We've demonstrated its efficacy in DVD1, and above all, immune modulation, which is what we're going to talk about here. Metals in cardiomyopathy. There's typically a metal burden in cardiomyopathy, and some of us are predisposed to being able to having trouble getting rid of our metals because of genomic methyl cycle abnormalities, and I unfortunately have a number of these, so I know all about this stuff. How do metals compromise us? They're toxins. They're not supposed to be there. They can displace nutritional minerals, kicking out good guys like selenium and magnesium. They can cause endothelial dysfunction, compromising blood flow to the heart, and they damage enzymes. Thus, we can't repair ultrastructural defects, and we have trouble making energy, ATP. This is just a partial list of enzymes, ATP-utilizing enzymes that are irreversibly poisoned by mercury. Many of these enzymes are critical for brain function and critical for heart function. Now, enzymes are like workers on a biochemical assembly line. They will grab a raw material, activate it with an energy source, release it, and then the next enzyme on the assembly line will modify it further. This is how we make proteins and enzymes, etc. The problem with metals are they will irreversibly bind to the active site, and they'll stick in it like a key that's not quite right for the lock, and that enzyme is lost. You have to make more enzyme, and it'll get poisoned by more metals. Our body is not very good at getting rid of metals. We accumulate metals over time. We're going to poison our enzymes, and this is going to play a role in heart failure, particularly cardiomyopathy. If we look at blood cadmium levels, they're greater in patients with cardiomyopathy. Smokers have more cadmium than non-smokers because tobacco plants are rich in cadmium, but smokers and non-smokers with cardiomyopathy have greater levels of cadmium than do smokers and non-smokers without cardiomyopathy. This chart looks at cause of death in individuals who live in North Carolina, tobacco country, in relation to tissue levels of lead and cadmium. People with high levels of lead tend to die of cardiovascular disease. The only people that die of cardiovascular disease with low lead are those with high cadmium. The more lead, the more cadmium, the more free radical stress, more cardiovascular disease, atherosclerosis, and as we're learning, heart failure. This was a really cool study. They did heart muscle biopsies on normal people, people with cardiomyopathy, people with heart failure due to valve disease or coronary disease. Now, the people with valve disease and coronary disease had greater concentrations of mercury, antimony, and arsenic than did normal people. But the people with dilated cardiomyopathy, myocyte dysfunction, and we don't know why, they had 22,000 times as much mercury in their cells as did the normal people. They had 12,000 times as much antimony and 250 times as much arsenic. Were they exposed to 22,000 times as much mercury as normal people, or genetically, or was there an acquired reason that they could not get rid of the metals? We don't know, but the metals certainly aren't doing their myocytes any good. The greater the concentration of metals, the worse was the ejection fraction, the more complicated the arrhythmia. So cardiomyopathy is clearly associated with metal overload and toxicity. Metals also cause immune system dysfunction. Metals cause oxidative stress. Too much Th1, too much Th17, not enough Treg. Problem in atherosclerosis, also as we'll see a problem in heart failure. They kick out selenium. we need selenium to defend against viruses. If we're low in selenium because of too much mercury, we have trouble thwarting or heading off a viral attack. And viruses can cause initial inflammation of the heart called myocarditis. And metals will compromise our immune response such that we're more likely to convert a transient myocarditis into a chronic inflammatory autoimmune myocarditis. Mercury causes oxidative stress. It directly catalyzes free radical reaction, just like lead and iron, binds to and activates selenium, directly wastes our key antioxidant glutathione, blocks its regeneration, blocks the regeneration of other antioxidant vitamins, and inactivates superoxide dismutase and catalase. Again, metals cause oxidative stress. This is an animal model with bulb C mice. These mice are predisposed to autoimmune disease. You're going to assign these mice to receive over 12 weeks standard mouse chow or mouse chow with methylmercury. At 12 weeks, you're going to sacrifice some of the animals and harvest B cells and T lymphocytes from their spleen and study them. You're going to infect the rest with an intraperitoneal injection of the belly with Coxsackie B3. Coxsackie B3 typically causes a non-lethal transient viral myocarditis in animals and in humans. You're going to record Th1 cytokine levels, interferon gamma and TNF-alpha, 3 and 7 days post-infection. You're going to sacrifice them on day 7 and look at the heart muscle. The question is, does methylmercury have an effect on the immune response and the severity of myocarditis? Now, if you take the T cells from the animals before you infect them with the virus, and you expose them to concavalin A. This is a molecule to which all T cells non-specifically will respond. You will see that the T cells of the animals fed mercury proliferate more rapidly. The metals are causing oxidative stress, putting a hair trigger on T cells and on B cells. So there's a non-specific upregulation of the immune response in the animals fed mercury. Then you're going to infect them with the Coxsackie B3 virus, and you're going to look at levels of Th1 cytokines, interferon gamma, and tumor necrosis factor alpha. Now, at 3 days, control animals have low levels of, before you infect them, have low levels of interferon gamma. If you just give them methylmercury, not much happens. But if you infect them with the virus, you see greater elaboration of interferon gamma as you would expect. But the animals pre-treated with mercury have a more exuberant Th1 response. At 7 days, interferon gamma is quieted down in all the animals except for those pre-treated with mercury. So you want an immune response to go kill the viruses, and then it's supposed to quiet down. It doesn't quiet down in the animals treated with mercury. Same situation with tumor necrosis factor alpha. If you look at the heart muscle and look at the number of macrophages, immune active cells, you will see greater values in the animals that were pre-treated with mercury. If you look at the percentage of the heart that's been damaged, there's 50% more tissue destruction in the animals pre-treated with mercury. Instead of having a transient viral myocarditis, they're on their way to a chronic, out-of-control, immune-mediated cardiomyopathic process. If you look at distribution of nutritional minerals in inflamed and non-inflamed heart segments, there's a disparity. High calcium is a result of free radical stress, it's sort of biochemical scarring. There's greater calcification in the animals treated with mercury. Iron is a pro-oxidant mineral. You see more in the animals pre-treated with mercury. Zinc is an antioxidant mineral. It is wasted in the mercury-treated animals. So this is in the inflamed region and in the non-inflamed region. So one of the reasons the people with cardiomyopathy might have the higher levels of metals is in response to infection, you may accumulate certain metals. So metals may lead to infection. Infection may lead to metal overload. There's a sort of a vicious cycle here. Now, let's look at another study. We've been talking about the heart, but oxidative stress is going to cause not just atherosclerosis and heart failure, it's going to increase your risk of autoimmunity in any organ of the body. The difference between lupus and atherosclerosis is it's the same immune response. The difference is which antigenic materials are stimulating the immune response in joints versus the heart. It's the same process. Let's look at immune system activation in adult rats. Brown Norway rats are genetically mercury sensitive. Lewis rats tend to be mercury resistant. You're going to divide them into a control group and a group that gets fillings. One group gets mercury fillings, amalgam, one group gets composite. At baseline and at 12 weeks, you're going to look at levels of immune system activation, plasma IgE levels that represent B cell activity, anti-DNP antibodies, which are T cell activity. You're going to sacrifice the animals at 12 weeks and look at tissue mercury concentrations, tissue immune deposits. Now, the brown Norway rats that are genetically mercury sensitive elaborate a brisk immune response with the mercury fillings. The Lewis rats that are genetically mercury resistant amount less of an immune response. We all vary in our genetics and in our susceptibility to autoimmunity from heavy metals, just as the brown Norway and the Lewis rats do. Now, if you look at blood mercury levels, they rise with mercury fillings. If you have mercury fillings, they're off-gassing mercury vapor, you're going to have mercury throughout your body, and you can see higher levels of mercury in all the organs of the body if you have mercury fillings. Same thing if you eat a lot of fish that contain mercury. IgG deposition is the product of B cell activation from T cell activation. With mercury fillings, you have a whole lot more in the kidney. Complement is an immune protein that is called in by the immune system to cause tissue damage. You have a lot more with the mercury group. And many organs are involved. Spleen, liver, adrenals have IgG deposition and complement deposition. These are fluorescent studies. You have a fluorescent molecule attached to an antibody that binds to human immunoglobulins. This is the kidney, and this looks just like the histology from a patient with lupus. So in these animals, you basically generated a lupus nephritis with mercury. It shows the mercury and other metals they predisposed and drive forward autoimmune disease, not just in the heart, but throughout the body. Again, this is all about immune system balance. If we don't want autoimmune disease, if we don't want atherosclerosis, we don't want heart failure, we want a lot of Tregs, and we want to quiet down Th1 and balance it with Th2. We don't want to see a lot of Th17. Now, there is an imbalance in cardiomyopathy. Let's look at frequencies of Tregs versus Th17 in 50 adults, 25 healthy controls with a normal ejection fraction, none with antibodies directed against the heart, 25 with dilated cardiomyopathy, their ejection fraction down 28%. There are certain antibodies that are found with great frequency in patients with cardiomyopathy. As we will learn later, not every protein made in the heart can be rendered antigenic, the subject of unwanted attention of the immune system. And there are 3 specific antibodies found in high frequency in people with cardiomyopathy. One is against the beta receptor. That actually causes inappropriate tachycardia. One against the acetylcholine receptor. That's associated with low heart rates and atrial fib. A third interferes with the ability to generate energy. So these people had cardiomyopathy with an obvious autoimmune component. And you see that in people, in the normal healthy people, 3% of their T cells are Treg, only 0.5% in those with cardiomyopathy. Conversely, the same mirror image we saw in atherosclerosis. With cardiomyopathy, you have a lot of Th17 cells. You don't have a lot of Tregs. If you look at plasma cytokines, if you have cardiomyopathy, you're going to be low in Treg cytokines, TGF-beta, interleukin 10. You're going to see more interleukin 6, which is Th1. You'll see more interleukin 17, more interleukin 23, which is Th17. So heart failure is associated with this Th1, Th17 inappropriate immune response. Another study, 80 adults, 18 healthy controls, 62 with congestive heart failure. Now, this was a mixed bag group of patients with heart failure. In 44%, it was due to arterial disease, 37% due to long-standing hypertension, 19% with dilated cardiomyopathy. So it's not just one cause of heart failure that's associated with an immune response. Any cause of heart failure will lead to a secondary immune response. Now, 28% of these had only diastolic dysfunction. Their hearts was stiff, but they had normal systolic function. Their ejection fraction was 50%. 34 had diastolic dysfunction and systolic dysfunction. They had hypocontractile hearts. They had low ejection fractions. And what you see higher levels of Tregs in the normal people, intermediate in those with diastolic dysfunction, the lowest levels in those with systolic dysfunction. This is all on a continuum. If these people with diastolic dysfunction, if they're left alone, their immune system will rev up further. Eventually, they will get systolic dysfunction. Same mirror image. The worse the heart failure, the more you see T17. If you look at the ratio of Th17 to Treg, it rises with increasing severity of heart failure. Doesn't matter the cause of the heart failure, the immune response is going to be the same. If you look at BNP, that is the protein released by the heart in response to stress or strain, as your levels of Th17 rise and Tregs fall, you see higher levels of BNP. Beta blockers and ACE inhibitors and the Th1 to Th2 ratio. 118 patients with advanced heart failure, ejection fractions 20%. Now, medical therapy involves neuroendocrine blockade, a beta blocker to block the adrenaline whip, an ACE inhibitor to block the angiotensin II whip. These drugs do improve outcome. They make a lot of sense. But some of these patients couldn't tolerate a beta blocker or an ACE inhibitor. So we're going to look at the Th1 to Th2 cytokine status with the use or non-use of beta blockers and ACE inhibitors. Now, norepinephrine is an adrenal hormone, or otherwise known as noradrenaline. High levels are elaborated in congestive heart failure. It's a distress signal. The worse your heart failure, the higher your norepinephrine, the more you're going to whip the heart. Those patients with heart failure that could not tolerate a beta blocker or an ACE inhibitor had the highest levels of norepinephrine. Those on a beta blocker had lower levels. Those on an ACE inhibitor had lower levels. Those on both had the lowest levels. These drugs are useful in heart failure, therefore the whip will be decreased. We would expect to see lower norepinephrine levels. Now, Th1 lymphocytes have a beta receptor. They will respond to norepinephrine by proliferating and making more cytokines. Th2 cells are not affected by adrenaline. So here, the higher your level of adrenaline, we would expect to have a higher Th1 response. We would expect that individuals who could not tolerate the beta blockers and the ACE inhibitors, higher norepinephrine levels, they're going to have a more elaborate Th1 response, higher cytokine levels. Let's examine this. If we look at the ratio of interferon gamma, which is Th1, to interleukin 10, which is Th2, you can see it is lower with beta blocker therapy. The ACE inhibitors didn't help much, and the combination was the same as a beta blocker, so beta blockers are helping. If we look at serum IL-6, another Th1 cytokine, both beta blockade, ACE inhibitors, and together lowered IL-6. If we take their monocytes and we look at how much tumor necrosis factor will be elaborated when we stimulate them, you see the beta blocker doesn't help much. The ACE inhibitor does, and there's a synergy. Different effector limbs of the Th1, Th17 response will be blunted to different degrees by different drugs. Thus, there's a synergy here. So conventional neuroendocrine blockade that we use to block these adrenal and autonomic nervous system whips also indirectly have an immune modulating effect, and we're happy to use them for that purpose. When skeletal muscle or cardiac muscle contracts, when the muscle fibers are moving, this involves thick and thin filaments ratcheting over each other back and forth. The thick filaments are made of myosin. The thin filaments are made of actin. The signal to ratchet back and forth, to contract and relax, is due to fluctuations in calcium within the cell fluid. Transducing changes in calcium to the activity of the thick and thin filaments are regulatory proteins such as troponins. There are 3 troponins that are found in our heart. They're found in heart muscle, and they're never supposed to be in the circulation. You only see them in the circulation when the heart has been damaged. The immune system's not used to seeing troponin in the circulation. Let's look to see if we can cause heart failure by exposing an animal to troponin. Now again, the immune cells are not supposed to see troponin because it's only in the cell membrane. So here we're going to take female mice and we're going to immunize them on day 0, 7, 16, 245 with MC troponin I, that's murine cardiac troponin I. So this is mouse troponin I, and we're going to inject it under their skin. Now, if we just inject it under their skin without presenting it to the immune system and stimulating the immune system is going to ignore it. So they administer it with an adjuvant. Friends adjuvant are proteins found in bacteria that mice and humans have been exposed to. They're going to rev up the immune response so the immune system will recognize the material, troponin I, that we are immunizing you with. When you get any vaccine, you get the protein of the microbe that you want the immune system to mount a protective immune response, but they always put in an adjuvant to rev up the immune system so it will recognize that. So these animals are given troponin I in a immune stimulatory fashion, and you're going to mount an immune response to troponin I. Another group gets troponin T, a third group gets vehicle, that's the control group. And you're going to evaluate the immune response, antibody or cell-mediated. And you're going to evaluate the effect on heart, pump function, inflammation, fibrosis, and the effect on survival. Now, what you do, you will take T cells from these mice that have been immunized and expose them to troponin I or troponin T in an in vitro test tube environment. If you immunize a mouse to troponin I and you expose it to low levels of troponin 1 and high levels of troponin I, you will get T cells to proliferate. If you immunize the mouse to troponin I and then expose it to troponin T, nothing will happen. The immune response will be specific to the protein administered. Look at tumor necrosis factor alpha, you'll see the same thing. So the T cell response to the protein that you immunize the mouse with will be specific for that protein that's not normally supposed to be present. If you look at antibody titers in the immunized mice at 21 days, those that were immunized with troponin I, you will see a T cell and B cell response to troponin I. Those that were immunized to troponin T, you'll see a T cell and B cell response to troponin T, but not to the other troponin. Again, it's specific. You will not see any antibodies against myosin. Well, they weren't immunized against myosin. Why would you have an immune response against myosin? Now, at 90 days, the situation changes. You will see that there are anti-myosin antibodies in the mice immunized against troponin I, but not against troponin T. So something was going on in the mice that were sensitized to troponin I, and they damaged the heart, causing myosin to leak out into the circulation, and we get a secondary immune stimulation. But that's only with troponin I, not troponin T. If you do muscle biopsies and you look at the inflammation score, these are normal cells. The dark spots are the nuclei, the rest are muscle fibers. As the degree of inflammation increases, you see infiltrates of T cells and macrophages. Now, the control mice, you see very little inflammation. Those that have an immune response to troponin T, you see low levels of tissue damage and inflammation. Those immunized to troponin I, you see a more elaborate immune response, infiltration of the heart cells with monocytes, macrophages, and T cells. More tissue damage is occurring. If you look at fibrosis, there's a lot more fibrosis in the animals that were immunized to troponin I. So immunizing an animal to its own troponin I, but not its own troponin T, brings on the microscopic appearance of cardiomyopathy. The immune system is attacking the heart because it's been sensitized to troponin I, which it's normally not supposed to see. It only sees it because you gave it to the mouse. Now, these are normal hearts. They're small. Mice immunized to troponin T, they're not bigger. Those that are immunized to troponin I, they got a dilated cardiomyopathy. Their hearts are larger, they have lower ejection fraction, and these mice begin to die of cardiomyopathy, heart failure. Why, if you immunize the mouse against troponin T, nothing happens, but to troponin I, it kills them? What's the difference here? Well, it turns out that troponin I is a regulatory protein. It's involved in the thick filaments and the thin filaments sliding back and forth. It also has another role. It's expressed on the external cell membrane of the myocytes. Troponin T and myosin are sequestered. So there is a target for these upregulated immune cells on the cell membrane of troponin I, so the immune system can get it. If you have an immune response to troponin T, but the immune cells can't get at it, nothing happens. That's why it's troponin I and not troponin T. There are just a limited number of proteins in the heart that serve as antigenic determinants and subject of autoimmune attack. Now, in another group of mice, before they had a chance to develop cardiomyopathy, they immunized them to troponin I or troponin T, and then they created a heart attack. They ligated the left anterior descending for an hour and released it, and looked at the size of the heart attack. Now, normal mice that didn't have a heart attack, there was no heart damage. Those that were not immunized, actually this group was not immunized at all, 52% of the heart muscle that could have been lost was lost. Those mice that had the same experimental heart attack, but they were sensitized to troponin I, had larger heart attacks. They had lower ejection fractions, more inflammation, more fibrosis. We'll get to this more a little bit later. Much of the damage that occurs in a heart attack is not due to interruption of blood flow. It's tissue damage carried out by the immune system that thinks this heart attack is a site of infection. Because cavemen didn't have heart attacks, they had infection. We respond to heart attack by sending in immune cells that will mount an immune response to these proteins they're normally not supposed to see and kill more heart. Again, these cells in our body are presenting proteins that express self. The sentinel cells, the macrophages, the dendritic cells that are exposed to microbes or that encounter damaged cells are going to digest these and present them on the cell surface. Now, it's not the whole molecule that's presented on the cell surface. It's little snippets that fit in the cleft between the MHC 1 or 2 molecule and the T cell receptor of T cells that are specific for that antigenic determinant. Let's look at a study, a similar study. We're going to look at antigenic determinants derived from troponin I and heart failure. We're going to take female AJ mice. You're going to immunize them with troponin I on day 0 and 7. You're going to harvest the T cells on day 21, and you're going to look at the activity of those T cells in a test tube situation. You're going to present them with troponin I and see if they will proliferate. And then you're going to administer to non-immunized mice, native mice, T cells that were obtained from mice immunized against troponin I. Can we transfer cardiomyopathy by taking T cells activated against troponin I and giving them to another mouse? And you're going to evaluate them at 3 weeks. Now, what you find in the recipient mice that receive the T cells, those that receive T cells from mice immunized against troponin I, they mount an immune response to troponin I. Those that receive control substance do not. If we look at cytokine levels in these mice that receive sensitized or non-sensitized T cells, those sensitized against troponin I, you see higher levels of tumor necrosis factor alpha, interleukin-1 beta, and interleukin-17 in the mice that receive T cells specific for troponin I. In other words, these T cells are attacking the heart of the recipient mice. If we look at inflammation and fibrosis in the animals that receive T cells activated against troponin I, there's a lot more tissue damage, they have larger hearts, they have lower ejection fraction, poor survival. So immunizing a mouse to troponin I will initiate an immune response that will damage its heart. If we take T cells from a mouse that's been immunized to troponin I, give them to another mouse, it will damage the heart. And again, it's not the immune response to troponin I, it's to antigenic determinants, little snippets of troponin I protein that are presented to the immune cells. Just as we chop up oxidized LDL into little fragments, present it to T cells in the artery wall, we're going to chop up troponin I and present it to T cells that mediate tissue destruction and heart failure. So what they did, they looked at the troponin I molecule and cut it up into little pieces. And they repeated this study with specific snippets, specific antigenic terminants, chains of amino acids that might fit in the cleft between the MHC molecule and the T cell receptor. And they found that most of the snippets did nothing. One snippet, snippet 9, caused some inflammation, but this snippet right here, snippet 11, this was the active antigenic determinant. If you give this snippet to animals, you destroy the heart completely. It doesn't look like normal heart, it looks like a piece of salmon. So there are individual snippets of the cardiac proteins that will be the target for this abnormal immune activation. If you knew what these snippets were, you could administer them to animals in an inflammatory or a non-inflammatory milieu and manipulate the immune response to the snippet or to the intact molecule. This was a mouse study. Is it appropriate to transfer this thinking to humans? Well, humans with heart disease have antibodies and T cells sensitized to troponin. We're going to look at 20 patients with a heart attack. You come to the emergency room with a heart attack, we're going to measure your troponin levels. It's not supposed to be there unless the heart's been damaged. And the measuring stick for cardiac troponin will be an antibody with a fluorescent tag that will bind to human troponin. So if there's troponin in your system, the antibody will bind to it. We can say, aha, there's troponin, you're having a heart attack. Well, what they did, they took exogenous troponin, man-made troponin, and put it in a serum sample of these patients. And then they looked at the ability to detect troponin with their standard monoclonal antibody. 10 patients had normal recovery. Nearly all of the exogenous troponin showed up on the assay as, yep, there's troponin. But 10 patients had low recovery. The monoclonal antibody against the exogenous troponin wasn't binding to troponin. Something was blocking its binding. What could that be? Well, then they looked for endogenous IgG antibodies pre-existent in the patients to troponin. And you're going to correlate the endogenous IgG antibody to troponin with detectability or non-detectability of troponin in their blood. And they found that those with low recovery, where the troponin antibody underestimated the amount of troponin released, the reason was these people had their own antibodies against troponin binding up the site, so the fluorescent antibody, the detection antibody, had nothing to bind to. And they used another troponin monoclonal antibody that recognized another site on troponin, got a more accurate reading. Now, this was published as a warning to clinicians. Patient comes in with chest pain and their troponin level is not high. That's not proof positive they're not having a heart attack, because if they have antibodies to human troponin, our assay won't work. But it also means something else. It means that these humans coming into the hospital with chest pain previously have leaked troponin into their blood where it's not supposed to be, and previously they mounted a T cell and B cell immune response. Is that a good thing or a bad thing? Let's look at IgG anti-troponin antibodies in humans experiencing heart attack. 108 patients with acute heart attack. All received standard medical and invasive therapy. You measure ejection fraction with a magnetic resonance scan on day 3 and 4, and then 6 to 9 months later after recovery. Now, you will look for high titer, high levels of IgG anti-troponin antibody. If you dilute the serum 160 times, and you can still see the antibody, that was considered high titer. 10 of the patients had high titer IgG antibody to troponin. Their immune system was previously revved against troponin, and 98 did not. At presentation, they were all pretty much the same. Those that did not have an immune response against troponin, 6 to 9 months later, their hearts had begun to heal. Their ejection fraction rose from 55 to 60%. Those that had immune activity against the cardiac protein troponin, they didn't get better. In fact, they got worse, suggesting that the immune response to troponin was causing ongoing damage to their heart consequent to the heart attack, as in the case in the experimental mice model. Troponin I and future event risk. Just over 1,200 70-year-old Finnish men. Some had known cardiovascular disease, the majority did not. You look at their standard risk factors, you're going to measure troponin I. Now, you're not supposed to see troponin unless you're having a heart attack. They classified as abnormal levels above the 99th percentile. And they found the cutoff was 0.021 in younger people, but it was higher in older people, suggesting that there was something wrong with the older people, there was something wrong with their heart, and they were oozing out troponin I. Maybe they'd had prior coronary disease or cardiomyopathy. 25% of their subjects had levels above 0.021 because most of these patients were older. And you're going to record over the following 10 years any cause mortality or new onset cardiovascular disease, and amongst the 835 70-year-olds that did not have cardiovascular disease, 116 developed cardiovascular disease. Of the entire group of 1,203 patients, 257 died. Question, is an elevated troponin just basically above the normal range associated with future event risk, mortality, or risk of new onset cardiovascular disease? Now here we're going to look at mortality risk in relation to one standard deviation rise in a physiologic variable. In blue, these are patients with baseline cardiovascular disease included. In red are those that did not have baseline cardiovascular disease. Diabetes, high blood pressure, smoking were important. So was troponin. If you have a high troponin I, your risk of dying is greater than that associated with high glucose, overweight, cholesterol, or age, suggesting that if there's something wrong with your heart and you got an immune response to troponin, that's a bad thing. New onset cardiovascular disease, clinical cardiovascular disease, is also related to high normal levels of troponin I, suggesting that our body is mounting an immune response to troponin I. We look at 10-year cardiovascular mortality, baseline cardiovascular disease included, baseline cardiovascular disease excluded. If you go from normal to slightly abnormal to more abnormal, your risk of mortality increases, your risk for new onset cardiovascular disease increases, suggesting that humans will mount an immune response to troponin I that is damaging to the heart. IgG antibodies against troponin in heart failure. 457 patients with heart failure, all with poor pump function, ejection fractions below 40%. 185 with ischemic cardiomyopathy. They had heart pump dysfunction due to coronary disease. 272 have a dilated cardiomyopathy. Let's look at serum antibody levels to troponin I and troponin T. Here we have low-level antibodies, dilution greater than 1 to 40, intermediate 1 to 80, high 1 to 160. Both the ischemic and the dilated cardiomyopathy patients had a measure, about 10% had high titers to troponin I. Very few, you see less immune activity to troponin T. Again, troponin T is not on the cell membrane, troponin I is. Therefore, we're going to have an immune response to what the immune system can see, troponin I. Troponin I efflux and dilated cardiomyopathy. 95 patients with non-coronary cardiomyopathy, you're going to see elevated troponin I levels in 20%. Now, they're not having coronary disease, but something's wrong and the cells are damaged or they're dying. They're releasing troponin I. In those that were positive for troponin I, they have lower ejection fractions, they have higher levels of BNP, the cardiac stress and strain marker, and they were more likely to die or have a cardiac event. So releasing troponin I, mounting an immune response is a problem. In coronary disease, cardiomyopathy, this has also been shown in valvular disease. Anything that's damaging the heart, releasing troponin I, we're going to get a secondary immune response that's going to damage the heart. What are the antigenic determinants What are the proteins that the immune system is reacting against in human cardiovascular disease? Well, in the artery wall, we know that it's the apoprotein B100, fragments of it that are brought into the artery wall by oxidized LDL, lipoprotein, and remnants. Heat shock protein, beta-2 glycoprotein, bacterial and viral proteins. If we know these sequences, we might be able to manipulate the immune response and accelerate or decelerate the disease. In the heart, it's troponin I, myosin, and there are immune responses to these other cardiac proteins. So how can we treat this? How can we blunt the immune response in heart failure? Well, one concept that was used in the past is a dialysis for antibodies. You remove or neutralize these antibodies from the blood, they won't attack the heart. Well, that'll get rid of the antibodies, but it won't deal with the T cell response. Or you can generate blocking antibodies, antibodies that will bind to antibodies specific for the heart or T cells specific for the heart, kind of like a biological warfare. Cytotoxic therapy. You know, if you have angina and you develop a malignancy and you get chemotherapy that'll kill cancer cells but kill immune cells, your angina will quiet down, your heart failure will quiet down because you're going to kill the T cells that are bothering the heart. Of course, that's not a really effective long-term therapy, but it just shows that the immune response is so key in atherosclerosis and heart failure. Or we can use milieu therapy that we'll talk about later. We can switch you from a Th1, Th17 bias to a Treg bias with pharmaceuticals such as pentoxifylline statins, ACE inhibitors, angiotensin receptor blockers, or nutritionally with fish oil, vitamin D, weight loss, antioxidants, testosterone, metal detox. Or could we neutralize the maladaptive T cell response to specific cardiac antigens, to specific cardiac proteins, or the snippets, the antigenic determinants, derived from those specific proteins? What if we knew what the antigenic determinants were that T cells are going to bind to in heart failure atherosclerosis, and we made them in the lab and we give them to you? We'd be giving you false targets. So T cells with receptors specific for that protein snippet would bind our imposter and maybe become inactivated. Or what if we gave them to you in a non-inflammatory milieu? If we give you fish oil and vitamin D and other substances that might cause a T regulatory response to that snippet. If you mount a T regulatory response to that snippet, if your immune system encounters it elsewhere, the Treg response will dominate over the Th1, Th17 response, and you won't go into attack mode. Would that work? Well, let's take a look at nasal inoculation with troponin in this mouse model. We're going to take mice and we're going to administer nasally 3 times a day, every other day for a week, murine troponin or murine troponin with an adjuvant to awaken the immune system and say, hey, pay attention. As a control, we'll give a cow protein, bovine serum albumin, or a brain protein called MOG. So we're going to administer these antigens, which will become antigenic determinants, into the upper airway. 2 days later, we're going to inject subcutaneously troponin with an adjuvant. Now we know that's going to initiate a Th1 and Th17 response. What's going to happen if we pre-treat these animals with nasal troponin? What they do, they harvest T cells from the spleen from these nasally and later subcutaneously inoculated mice, place in tissue culture with the target troponin, and we're going to see how readily those T cells respond and proliferate. Now, the animals that did not receive any nasal immunization, that then get the subcutaneous troponin, rip-roaring Th1, Th17, their T cells are going to proliferate when you give them their target. Those that were treated with nasal troponin without an adjuvant and then got subcutaneous troponin, there is a blunting of the immune response. Those that had a more effective immunization with nasal troponin and the adjuvant, they have a very, very, very low immune response. So the Th1, Th17 response to injected troponin is blunted by pretreatment with nasal troponin and adjuvant. What's going on here? The response, interleukin-6, interferon gamma, is also blunted by inoculation with nasal troponin. Now, was the response to troponin blunted by nasal inoculation against troponin or just nasal inoculation in general? Well, the animals that were nasally inoculated with the bovine serum protein and the brain protein that don't react with troponin, they responded to subcutaneous inoculation with troponin with a brisk immune response. It was only those that were inoculated with troponin where it was blunted. The T regulatory response is antigen specific. You'll only make Treg cells to an antigenic determinant if you give that antigenic determinant in a regulatory milieu. Now, our nasal passages and our gut is a Treg rich environment. When you think about all the different foods we eat and all the molecules that we're going to inhale, we don't really want to recognize all of them as a threat. Otherwise, we'll have lifelong sneezing and diarrhea. So Mother Nature in her wisdom, these surface areas of our body is rich in Tregs, so we don't recognize these innocuous substances and mount an immune response. So if we give you troponin into this Treg-rich environment, you're going to make a lot of Treg cells. So you're going to, all of a sudden, you're going to have a lot of Treg cells to troponin. If they get into the artery wall and respond to troponin, or into the heart and respond to troponin, or elsewhere in the body and respond to troponin, they're going to release interleukin-10 and transforming growth factor beta, which will downregulate all Th1, Th2, and Th17. So if we can immunize you, as you immunize these mice to troponin I, mount a Treg response, you're going to protect them from cardiovascular disease related to subsequent exposure. It would really be neat to have a high concentration of Tregs specific for arterial wall and myocardial proteins in our patients with cardiovascular disease. They would prevent or downregulate this maladaptive immune response. So what's going to happen if we create this Treg response in animals against troponin and then give them a heart attack? So we're going to take the mice, we're going to nasally administer 3 times every day for a week, troponin and the adjuvant, and then we have these controls. 2 days later, you're going to create a heart attack. You're going to ligate the left-hander sending for an hour, then you're going to release it. And there's going to be a free radical storm, influx of immune cells, cytokine elaboration. Remember, much of the damage is done by the immune system. Half of the damage done in a heart attack is the responsibility of the immune system. What effect will nasal vaccination 2 days before the heart attack have on the extent of the damage? The infarct size, the percentage of the heart muscle lost in control animals was very low. In those, it was 13%, it was very high. In those that did not have a Treg response to troponin, 13% of the heart muscle died. Those immunized against the brain protein, there was really no significant protection. Those immunized 2 days earlier against troponin, only half as much heart muscle died. Because, again, much of the damage in a heart attack is the immune response to the released heart muscle. If you have a Treg response, you won't kill those heart cells. If you take these T cells 24 hours into the heart attack, remove them, put them in a test tube situation, and expose them to exogenous troponin, the control animals they proliferate rapidly because within 24 hours they've mounted a T cell response to troponin. You give them troponin, they go crazy. The animals that had a pre-heart attack Treg response, the Treg cells prevent the other cells from responding to troponin. That would be a correlate of less tissue damage. These are the control animals. The front wall of the heart's blown away. The troponin-treated animals, much less damage. Mortality was 44% in the untreated animals. Those immunized against troponin I, it's 14%. Ejection fractions better preserved. if we look at the degree of T cell infiltration, it's much greater in the control animals than in the animals that had Treg response. There are fewer macrophages, fewer T cells. The percentage of T cells expressing interferon gamma, Th1 is less. Those expressing interleukin 10, Treg is upregulated. Less tumor necrosis factor alpha, less interleukin 6. All right, so if we vaccinate these animals and create a Treg response, a couple days before the heart attack, they're going to have lower heart attacks. Of course, we don't know when you're going to have a heart attack. What happens if we immunize the mice to troponin I 1 hour into the heart attack, like in the mouse emergency room? So we take these mice. The first thing we're going to do, we're going to create a heart attack. We're going to ligate the left angiosensing for an hour, then we're going to release it. 1 hour later, in the emergency room, we're going to administer nasal troponin I. What effect will immunization against troponin 1 hour into the heart attack, this troponin's already being released, what effect will it have on outcome? There was a 40% reduction in infarct size, all right? Because it takes a while for your immune system to respond to the exposure to troponin. So the damage is going to be delayed until you can get enough T cell proliferation. If we intervene at 1 hour and create a Treg response, we'll block the T cell proliferation, you're going to have a smaller heart attack. So in theory, if we did this with humans in the emergency room, we would have smaller heart attacks. There's no reason to believe that this is not possible, and of course more research needs to be done, but it would make a lot of sense. If you look at T cell proliferation, it is blunted by the animals that had the Treg response. The amount of damage done was related to the T cell response, which was blunted by initiating a Treg response 1 hour into the heart attack. Tolerogenic exposure to cardiovascular antigenic determinants. If an antigen-presenting cell presents the appropriate snippet to a resting T cell with the co-stimulatory molecules, it's going to activate, it's going to go out and kill. If it presents the antigen without any regulatory molecules, nothing happens. The T cell dies off, it goes anergic. If it is presenting the antigenic determinant with regulatory signals in a regulatory milieu, in a tolerogenic milieu, we'll talk about generating that with testosterone, fish oil, and vitamin D, that T cell, instead of going Th1, Th17, will go Treg. So if we know these antigenic determinants and administer them in the proper fashion, such as in the mice study of having them inhale it, we're going to initiate a Treg response, and that should be helpful. And I'm not going to tell you exactly what we're doing with immune modulation because I don't know all the details, but I can show you a few more outcomes before we conclude this section. This is SJ, a 73-year-old man with lower extremity vascular disease. He had intermittent claudication, presented to an outside hospital in February of 2009 with heart failure. Now, he had mercury fillings, he had iron overload, and he was a smoker, all causes of free radical stress. A heart cath was done showing only modest coronary disease. So he had a non-coronary cardiomyopathy, really a dilated cardiomyopathy. And he was treated with a diuretic, an ACE inhibitor, and a beta blocker. And I saw him 4 months later in June. And he was improved, but he was still in heart failure. I did an echo, and he had a horrible looking heart, diffuse hypokinesis, mitral insufficiency, ejection fraction 30 to 35%, moderate mitral insufficiency, pulmonary hypertension, as you would expect. And this is on standard medical therapy. So I adjusted his medical therapy. I added neuroendocrine blockade. I increased his lisinopril. I added spironolactone. I increased his beta blocker, carvedilol. And I provided bioenergetic support for the mitochondria, CoQ, carnitine, ribose, etc., antioxidants and minerals, which is recommendations to all my patients with cardiovascular disease. And I saw him a few months later. He was feeling a little bit better, but his echo really wasn't any better. I hadn't made major headway in resolving his cardiomyopathy, so we began him on immune modulation, and he came back a year later. He's feeling pretty good. He took himself off lisinopril and his diuretic furosemide. We repeat his echo, and it's looking a heck of a lot better. The ejection fraction was 30 to 35%, moderate mitral insufficiency, minimal mitral insufficiency, ejection fraction's better. his cardiomyopathy responded to immune modulation. Why? We're blocking the Th1 and Th17 response to the heart muscle and creating Treg responses. There's just another view of the peristernal longus showing the improvement in pump function. Diabetic cardiomyopathy. HS was a man who at one point was obese, and there's an obesity cardiomyopathy due to inflammatory cytokine release. He had lost 100 pounds before he met me. He had diabetes, hypertension, moderate kidney disease. His BNP was over 1,000. It's supposed to be 100. And he's short of breath. He's short of breath. He's got ankle swelling. We do an echo. It's not looking so good. Ejection fraction 20 to 25% actually. The heart was stiff, pulmonary hypertension. So we began to treat him with neuroendocrine medical therapy, a diuretic, full nutritional support, and I began him on immune modulation. And he improved a little bit, but he wasn't feeling great. We added testosterone therapy, which is an immune modulator. We began to treat his diabetes with insulin. He began a program of metal detoxification. He worked with another practitioner who's very good with homeopathy. We treated him with external counterpulsation, and he was getting better. And then in August, he comes down with shingles. He gets real sick. He can't eat. He's dehydrated. He's hospitalized. Now, the first thing we do in the United States when you're hospitalized is stop the supplements that are good for your heart. Now, they're in the literature, coenzyme Q carnitine, but we always stop them when we put you in the hospital and we give you drugs. So anyways, they treated him and they gave him antiviral therapy. They did a really good job taking care of him, and then they sent him home without any of his supplements, and they had stopped almost all of his heart drugs. And I get this distress call from his kids. They sent him home without his heart drugs. And I thought, man, with this heart, he's going to go into pulmonary edema and die. Get into the office. So he comes to see me, and I'm expecting to see this guy with a lot of heart failure, but he's got a rash from shingles, but he's feeling good. There are no signs of heart failure. His BNP is only 200, so I repeat his echo, and it's looking an awful lot better. It's nearly normal. The ejection fraction is 40 to 45%. He went from 20 to 25% to 40 to 45%, and this was a result of all the things we did, immune modulation, and maybe the antiviral therapy they gave him for his shingles helped. Whatever, we dealt with the immune response and his cardiomyopathy resolved. This just shows you why it's important to listen to me giving you all this horrible biochemistry. There's a reason for it. You don't have to remember the details, but I need to convince you that this is the key driving force in your atherosclerosis and heart failure. For if we deal with it, this sort of stuff happens. Now we'll move on to the next section where we talk about the role of visceral fat, sleep apnea, allergy, and endotoxin load as a driving force of autoimmunity. Thank you for your attention with this section. Click on to the next section at this time, please. Thank you. This section of DVD2 deals with overweight, sleep apnea, allergy, and infectious burden as driving forces for immune dysregulation in heart disease, atherosclerosis, and heart failure. Now, when you sit down to eat your steak, you'll notice the juices are red, and that's because it's blood. Now, if you look at the steak before you cook it, the muscle, which is well vascularized, is red. There's a lot of blood there. The fat, which is relatively metabolically inactive, has less vascularity. Fat has a limited blood supply compared to muscle. Now, visceral fat, our beer belly fat in our guts, Mother Nature didn't plan on this. The blood supply to fat is low, but it's particularly limited in visceral fat. The more visceral fat you have, the colder it is, the lower is the level of oxygen. If we measure temperature and oxygen tension in visceral fat, it is low in overweight individuals. The heavier you are, the colder the visceral fat is, the lower is its oxygen tension. That's not compatible with normal physiology. If we have visceral fat, the hypoxia, the low oxygen tension, causes the heart cells to become dysfunctional. They actually die. And something's wrong here, so what they're going to do, they're going to release monocyte chemotactic protein and other chemotactic factors, the bone marrow will respond by releasing mononuclear cells that infiltrate visceral fat and release Th1 inflammatory mediators. The visceral fat releases monocyte inhibitory protein to keep the white cells from leaving. The more visceral fat, the lower the oxygen, the greater will be the monocyte and later macrophage infiltrate. Now, that is deleterious. So basically, Mother Nature doesn't understand visceral fat, and it thinks it's an infected mass. So if you have a lot of visceral fat, you're walking around with functionally infected tissue full of macrophages and T cells making interleukin-6, tumor necrosis factor alpha, etc. This is a big problem. Now, if you lose the weight, will you lose the inflammation? Let's look at macrophage exfiltration with weight loss. Here we're going to do fat biopsies. We're going to do subcutaneous fat biopsies in 24 individuals. Now, we prefer to do adipose, visceral fat biopsies, but most people don't like having needles stuck in their belly, so we do subcutaneous fat biopsies. 7 lean controls, 17 morbidly obese individuals undergoing bariatric surgery. And we're going to evaluate the extent and characteristics of the macrophage infiltrate, the gene expression of the adipocytes and the macrophages, and what effects of weight loss. Well, they undergo bariatric surgery and they lose 50 pounds, which is similar to what our patients achieve with 3 rounds of our HCG program. So 50 pounds is a pretty good surgical result. And their weight falls from 282 to 233. Their BMI falls 8 points. Leptin is released by fat cells in proportion to their fat mass and their size. Leptin level falls. Their adipocytes get smaller, C-reactive protein falls. All right, CRP is made in the liver in response to inflammatory mediators. Why is CRP falling with weight loss? Is the macrophage infiltration affected? Are the characteristics, the degree of immune activation of the macrophages affected by weight loss? Let's take a look. Normal fat cells contain very few resident macrophages, but if you have visceral obesity, your fat cells are surrounded by activated macrophages releasing Th1 cytokines. Here we're going to stain for IL-10, which is a Treg cytokine. You don't see much in the visceral fat. After they lose weight, the white cells leave and you start to see the interleukin-10. So lots of visceral fat, a lot of hypoxia, and infiltrate. You lose the weight, the white cells leave, the immune activity downregulates, thus your C-reactive protein falls and you're going to get better. You can also look at transcription of specific genes of the fat cells, the adipocytes, or the macrophages. Under the visceral fat conditions with hypoxia, the DNA will be read differentially to elaborate inflammatory proteins. After you lose weight, the residual fat cells and the macrophages change the rate of protein production into a non-inflammatory mode. So with visceral fat, you're loaded with white cells that are inflammatory. You lose the weight, the white cells leave, the residual cells shift to a non-inflammatory, more of a Treg environment. That's why weight loss is so important. When you lose the weight, you lose the inflammation. This inflammation is driving atherosclerosis and heart failure. If you have advanced cardiovascular disease, you're overweight. If I don't help you lose weight, I'm not going to quiet down the immune response. Now, in a sense, we are what we eat. Let's look at dietary fatty acids and adipocyte, that's fat cell IL-6 release. We're going to take rats and we're going to put them on an isocaloric diet. They all get the same number of calories. They all get 14% protein, 76 carbohydrate, 10% fat, but the fat could be varied. It could be saturated, monounsaturated, or polyunsaturated, and there was, by design, there was no difference in their weight at 4 weeks. Then you're going to take some of their visceral fat, you're going to measure release of interleukin-6, a Th1 cytokine, at rest and after you administer epinephrine. Now remember, the Th1 cells will respond to epinephrine with upregulation. Macrophages within fat will also respond to epinephrine with upregulation. So the animals fed coconut oil, which is a saturated fat, so they had a lot of 12-carbon lauric acid. Those that got sunflower oil, that is a polyunsaturated fatty acid, linoleic acid. Those that got olive oil, that is a monounsaturated fatty acid, rich in oleic acid. So they all got the same amount of fat. One group was saturated, one was polyunsaturated, one group got extra virgin olive oil. Now, saturated fats will activate the toll-like receptor on monocytes and macrophages, adding to the hair trigger. Polyunsaturated fats don't do it as much. Monounsaturated fats don't do it at all. So they're all the same weight. They have the same amount of visceral fat, but the fat is different depending on whether they are getting saturated fats, polyunsaturated, or olive oil. And if you look at the fatty acid composition of the visceral fat, the omental fat, it reflects the dietary mixture of fatty acids. So now let's look at release of IL-6 from visceral fat cells, adipocytes, in the animals fed coconut oil. At rest, it's pretty high. You give them epinephrine, nothing happens. That's because it's already maxed out. You've stimulated the toll-like receptor. These cells are all in TH1 hyperdrive. Those that get the polyunsaturated diet, the sunflower oil, they're releasing less IL-6 at rest, but if you stimulate them with epinephrine, they'll release more. The animals that received extra virgin olive oil, which is an antioxidant, anti-inflammatory molecule, they're releasing less IL-6. You can give them all the epinephrine you want, nothing happens, because this is suppressing the TH1 immune response. That's why a Mediterranean diet is so good for people with cardiovascular disease, rich in extra virgin olive oil that quiets down the immune response. Change in CRP versus change in weight. We're going to look at 1,222 18 to 70-year-old residents of Nottingham, England. We're going to record body weight and CRP in 1990 and again 10 years later. Now these residents of Nottingham, instead of running away from the sheriff of Nottingham like they were supposed to, were sitting around watching TV, and they gained weight. They went from 160 to 167 over 10 years, which is what we see in Western societies. And lo and behold, their CRP as a group went from 1.2 to 1.8. Does that reflect the weight gain? This is their baseline BMI distribution. 46, basically 50% were not overweight, 40% were overweight, 11% were obese. Over 10 years, they all gained a little bit of weight. Here we're going to look at change in CRP related to 10% bracket decile of change of CRP. Those who lost the most weight, their CRPs fell. As you lose less weight or gain more weight, there's a fairly linear rise in CRP. For every pound you gain, your CRP is going to rise by 0.05 points. So if you gain 9 pounds, that translates to a 30% increase in cardiac risk as a function of the rise in CRP. Here we're going to look at 20 otherwise healthy individuals presenting for weight loss surgery, laparoscopic gastric banding. You're going to lose weight with that. You're going to look at inflammatory cytokine expression in adipose tissue, fat, and in the liver. They're going to focus on SOC3, suppressor of cytokine signaling 3. This molecule is a key mediator of insulin insensitivity in the liver and leptin insensitivity in the hypothalamus. When it is activated, you become leptin insensitive, and that makes it very difficult for you to lose weight. When it's activated in the liver, you become insulin insensitive, you become diabetic. Sugar, saturated fat, inflammation in general upregulate SOC3. We don't like to see that at all. What happens if we lose weight? If we look at subcutaneous fat tissue, we see less weight loss, IL-6 falls, TNF-alpha falls, adiponectin, which is another adipokine released by fat cells. Actually, it's a good guy, it goes up. If we look at liver tissue, we see a reduction in interleukin-6 and a reduction in suppressor of cytokine 3. So with weight loss in the serum, in the fat, and in the liver, you accrue anti-inflammatory benefits. And adiponectin rises. Leptin is released by fat cells in proportion to your fat mass. The heavier you are, the higher is your leptin level. Adiponectin is released when your fat cells are small or when you're losing weight. Adiponectin is protective against cardiovascular disease. It rises when you lose weight or when you exercise. Here we're going to look at adiponectin levels in individuals with coronary disease and healthy people. And the cardiac patients are down here. The healthy people are here. They have higher adiponectin levels. If you have a high adiponectin level, you're at lower risk of cardiovascular disease. The lower your adiponectin, reflecting greater degrees of obesity, the greater is your risk of cardiovascular disease. Adiponectin is made by fat cells when they're small or when you are losing weight. It will accumulate within the artery wall of a stressed or biochemically injured artery, such as a patient with atherosclerosis, and have an immune downregulatory effect. So we want to see adiponectin rise, we want you to exercise, we want you to lose weight. Thus, in our program that is designed to treat cardiovascular disease and prevent cardiovascular disease with particular attention to immune modulation, we have decided to include a weight loss program. We use the Simeon's HCG methodology to help our patients lose weight, and this has worked out quite well. Of our first 350 female patients, at 43 days on average, they lost 22 pounds. Men lose 30 pounds. 100 women have undergone 2 rounds of therapy, losing 13% of their baseline weight. 21 women have undergone 3 cycles of therapy, losing on average 52 pounds, which is as good as you get with bariatric surgery, and this is simply a medical therapy. And if we help you lose weight, we're going to lower inflammation, get rid of Th1, get rid of Th17, more Treg. That's good for your cardiovascular system and your entire physiology. PF came to see me in 2008. She did not have known cardiovascular disease. She had a really strong family history, so she wants risk factor reduction. She has a high LDL, a high LPA, hypertension, homocysteine was kind of high, didn't have a lot of heavy metals. She had a high CRP of 6.3. You want to see it at 2 or below. And she was overweight. She had a body mass index of 33, normal's 25. I put her on an ACE inhibitor that we'll talk about later, niacin to lower her LDL and lipoprotein binding therapy. We determined she had sleep apnea, which is related to weight. We put her on CPAP. And her weight went up, her LDL fell, her lipoprotein A fell, but her CRP kept going up. And I switched her from niacin to simvastatin, and her LDL fell, and her CRP fell. Statins will lower CRP. They downregulate the immune response. Then in 2009, I increased the simvastatin, and she began our HCG program, and her weight fell slightly, and her CRP fell. With the first round, weight fell 216, 187. CRP didn't fall. It was 10.1, but her hypertension and sleep apnea improved. She underwent another round of therapy, and then a third round. She wound up losing 61 pounds, 28% of her body weight. Her BMI went from 36 to 26, and all of a sudden, no more CRP. Because the driving force behind her CRP was her overweight and her sleep apnea, which we'll learn in a moment is due to overweight. More energy, mood is increased, arthritis and reflux decreased, her risk for cardiovascular disease was decreased. Not from my drugs, not from my nutritionals, not from her CPAP, but by losing weight. And if you can lose weight, you lose the inflammation. Here we contract her body mass index with CRP or her weight with CRP. It tracks quite nicely. Another patient, Kay, is a 75-year-old woman who presented to me 10 years ago when she was 65, high CRP, high LDL. Her coronary calcium score was over 2,000. Now, normal is 0. Mine is 0. 2,000 is really high. We did a stress cycle. It was abnormal. I felt she had coronary disease. She did not want to undergo a heart catheterization, which turns out to have been a good decision on her part. And I began to treat her with antioxidants, essential fatty acids, CoQ, and anti-nanobacterium sanguineum therapy. And her CRP fell. Her weight didn't fall, her CRP fell, and we began to decalcify her coronary arteries. We stopped the COMET therapy, and over the years, I added various drugs and nutritionals, and her weight was about the same, and her CRP was about the same. Well, then she entered our weight loss program. She loses 30 pounds. Her CRP falls to 1.8, more energy, blood pressure's normal, off drugs. I repeat her stress test, it's almost normal. when you have an abnormal stress test, that doesn't mean heart catheterization is mandatory. It means that medical attention is mandatory. If we can deal with the causes of this disease, we can stabilize the disease or maybe make it go away. And if we do our job correctly, we can stabilize you for up to a decade. And again, we can track her CRP with her weight and her BMI, and they track quite well. Sleep apnea. What is sleep apnea? It's quite prevalent in adults with cardiovascular disease. With sleep apnea, you don't breathe well at night. You stop breathing, and you'll be tired and sleepy throughout the day. We can rate the severity of your symptoms with the Epworth Sleep Scale, which is a questionnaire. We can do a sleep latency test. We put you in a quiet room without a lot of stimulation and see how long it takes you to fall asleep. I hope that doesn't happen to you while you're watching this presentation. So we can measure the severity of your sleep apnea, and then to confirm sleep apnea, you spend the night in the sleep lab, undergo a sleep study. It's technically called polysomnography. We look at your AHI, apneic or hypopneic events per hour. If it's 5 to 20, it's mild sleep apnea. 21 to 30, it's moderate. Above 31, it's severe. Now, you should have an AHI of 0, but they graded it as mild, moderate, severe to determine whether you qualify for insurance coverage of therapy. Now, the old thinking was that sleep apnea was a localized disorder of the upper respiratory tract. What happens with sleep apnea is that your airways collapse, and though you just can't breathe, you can take a deep breath, but no air comes in. When this is occurring, your body becomes hypoxic, and your body is not resting. It activates. You're not resting well. So because we felt that the problem was in the throat, the therapy was surgery. They would ream out your throat, get rid of all the fatty material, and that helps some, but not everybody. An improved approach is mandibular repositioning. Biological dentist, the leader in Northwest Ohio is Dr. Michael McVicker, will make a mouth guard, kind of like what you wore when you played football, to keep it. It changes the angle of the jaw to make it less likely for your throat to collapse. And those therapies are helpful, but they don't help everybody because there's also a central component of sleep apnea. The biorhythms in the brain that control breathing have been compromised. In 1997, a paper came out suggesting sleep apnea was a systemic inflammatory illness because sleep apnea is associated with other inflammatory diseases, hypertension, diabetes, metabolic syndrome, obesity, cardiovascular disease, high levels of CRP. Question: is sleep apnea the cause or the consequence of inflammation? Is sleep apnea the cause or consequence of obesity? Could sleep apnea actually cause obesity? In this study, we're going to take 52 overtly healthy and medication-free overweight American men, none with hypertension, diabetes, smoking, cardiovascular disease. They're overweight without a lot of sequelae, except 36 had newly diagnosed sleep apnea, 16 were overweight, but they didn't have sleep apnea. You're going to evaluate their symptoms by the Epworth Sleep Scale. You're going to do a sleep study to rate the severity of their sleep apnea. You're going to do a carotid ultrasound looking for plaque and looking for IMT. Then you're going to measure inflammatory mediators at 5 in the morning after a poor night's sleep. You're going to correlate the ultrasound findings, the inflammatory mediator levels, with the severity of sleep apnea. And what you find, this apnea-hypopnea index in the obese controls, it wasn't normal, but it was low. It was 3. Mild sleep apnea, it's 11. Moderate to severe, it's 48. And the more severe your sleep apnea, the more frequently you stop breathing at night, the more sleepy you're going to be during the day. That makes sense. The greater will be your CRP. The greater will be your interleukin-6. The greater will be your interleukin-18. That's another inflammatory mediator. So repetitive total body hypoxia from sleep apnea does to your body kind of what hypoxia in visceral fat does when you're overweight. It initiates an inflammatory immune response. Here it's the entire body. If we look at carotid intermediate thickness or plaque as markers of atherosclerosis or a propensity to atherosclerosis, the worse your sleep apnea, the more atherosclerosis you see. And the carotid IMT, the marker of plaque predisposition, rose in relation to CRP, interleukin-6, interleukin-18. Obesity and sleep apnea produce inflammation. inflammation, Th1, Th17, low Treg, of course you're going to have more atherosclerosis. This makes a lot of sense. If you look at TNF-alpha and interleukin-6 in normal people, and there are some people that are just tired in the day, they don't have sleep apnea, but they're tired all the time, they have higher levels of inflammatory mediators, and the sleep apnea patients have the most. Inflammation makes you tired. My patients without cardiovascular disease who lose weight, one of the things they say, gee, I'm not tired anymore because there's less inflammation. If you look at tumor necrosis factor alpha, in normal people, obese non-sleep apnea, obese sleep apnea during the day and at night, in normal people, you make less TNF during sleep because your body is in a relaxed mode. Those who are overweight but don't have sleep apnea, their body's not relaxing as well, you're still making more TNF at night. You got sleep apnea, your body's not relaxing during the day, during the night, you're making more TNF during the day and at night. Same relationship with interleukin-6, higher levels of leptin. Leptin, the higher your leptin, the more gummed up will be the command and control centers in your hypothalamus, the more difficult it will be for you to lose weight. Obese people have high leptin levels. Obese sleep apnea have higher leptin levels. Why it's so difficult to lose weight if you're overweight, particularly if you have sleep apnea. This is a graphic of obesity in America, and our obesity peaks in our 60s. This maps sleep apnea in men and in women, and it pretty much tracks obesity. Women tend to gain weight later in life, so they develop sleep apnea later than life. Obesity is the key cause of sleep apnea because inflammation here is inflammation here is inflammation here, and we get sleep apnea. Etanercept, or Enbrel, will block the tumor necrosis factor alpha receptor. In rheumatoid arthritis, it is a Th1, Th17 attack on the joints. If you administer this drug to RA patients, they get better. They feel a lot better because you're blocking inflammation. Well, if TNF is a bad actor in the joints and it's a bad actor in the heart, why don't we give this drug to people with heart failure? We're going to knock out TNF, they ought to get better. This study was done, the patients did worse. They were more likely to die. Well, the problem here is Mother Nature didn't give us TNF to kill us. Actually, we need a little bit of TNF for normal physiologic function. When our body is under stress, TNF can mediate tissue damage, but it also, at low levels, keeps our cells from committing suicide in response to stress. We wipe out all the TNF, the cells of the failing heart are more likely to commit suicide, so this was a bad idea, wiping TNF off the map. There are other drugs, such as pentoxaline, that we'll talk about in a later section, that decrease the transcription rate of TNF. The higher your TNF, the greater will it fall with pentoxaline. But if you're not making much TNF, not a whole lot happens. So it is a modulator of TNF. And we will use pentoxaline in the treatment of heart failure and cardiovascular disease. But we know that etanercept just knocks it out. It's useful in rheumatoid arthritis. So here, we're going to take people with sleep apnea and give them one IV treatment of etanercept to block tumor necrosis factor alpha in their body, and you're going to repeat their sleep study. They don't stop breathing, and they're less likely to fall asleep during the day because you wipe out TNF, biorhythms come back, less sleep apnea. You wouldn't do that long term because of the side effects, but it just shows how important inflammation is in a cause of sleep apnea. Obesity causes sleep apnea. Sleep apnea causes obesity. When we're overweight, we're making inflammatory mediators. They are present in the throat. They're present in the brain. We have sleep apnea. When we have sleep apnea, we have total body hypoxia. We make inflammatory mediators, and that causes fat to be deposited in the belly as opposed to the periphery. The more fat in the belly, the more inflammation, the more sleep apnea, we get into these vicious circles. We can break this vicious circle with weight loss. Here's a study of individuals presenting for bariatric surgery. They lost a considerable amount of weight, 120 pounds. Their BMIs fell from 51 to 32. Their sleep apnea parameters improved. Those that still needed CPAP needed lower pressures applied. So weight loss will help with sleep apnea. Here's a study looking at less drastic weight changes and the frequency of sleep apnea. 690 Wisconsin state employees, you look at their BMI, their body mass index, and index of obesity, and you do a sleep study at baseline and 4 years later. Those that gained a lot of weight, 10 to 20% of their body weight, their apnea-hypopnea index increased the most. Individuals who lose weight, they have less sleep apnea as a reward for weight loss. So if you lose 20% of your weight, there's going to be a nearly 50% reduction in apnea and hypoxia. Conversely, if you gain 20% of weight, you're much more likely to have sleep apnea. If you have sleep apnea, it's going to be severe. So weight is the key driving force behind sleep apnea in the United States. 2/3 of American adults are overweight. Body mass index, which is your weight in kilograms divided by the square of your height in meters, we say that 25 is normal. And 2/3 of Americans are above 25. That's a big problem. A lot of visceral fat, a lot of inflammation. Of course, we're having diabetes, hypertension, heart disease. Now, we say 25 is normal, but it really isn't. If we look at long-term mortality in non-smoking middle-aged nurses, if you've got a BMI of 25 versus a BMI of around 19 or 20, you're still 70% more likely to die of cardiovascular disease. So we say 25 is normal, that's okay. You're 30% more likely to die overall and 70% more likely to die of cardiovascular disease. Our perception of normal is no longer normal, all right? I have a BMI of about 22. I'm actually normal because this weight is associated with longevity. Many of you are heavier than me, but you say, gee, I'm normal because a lot of healthy people look like me. My BMI is 25. You're deluding yourself. We're not supposed to have visceral fat. If we have any degree of visceral fat, we have inflammation. So it's really important not to delude yourself. We're really interested in not your weight, not in your BMI, but in your waist circumference. We want to get rid of visceral fat. Some people hold all their weight in their belly. That is much more of a problem than the female distribution where the weight is in the hips or the buttocks. That fat is not inflammatory, but visceral fat is. So we want to help you get rid of all your visceral fat. Thus, if you have heart disease and you're overweight, we're happy to help you lose weight. If you don't have heart disease and you're overweight, and you don't want to get heart disease, we're also happy to help you lose weight. If we can help you lose weight, we are going to dramatically improve your current health and decrease your risk of multiple disease states. So we're quite happy to do this. Let's talk about allergy, another cause of chronic maladaptive upregulation of the immune system. We're going to look at the relationship between allergic symptoms and coronary heart disease in 31,000 adult Americans. We're going to look at your standard risk factors, lipids, high blood pressure, diabetes, and allergic symptoms. Now, 36% of the subjects had none. 46% had rhinoconjunctivitis, which is a fancy way of saying runny nose, itchy eyes. 18% had intermittent wheezing. 6% had coronary disease. Let's calculate your risk for coronary disease from your standard risk factors and compare risk factors to allergic status as a predictor of coronary artery disease. If we look at coronary disease relative risk, compared, people with no allergy were considered low risk. Those with the watery eyes, the runny nose, were 20% more likely to have coronary disease. Those with wheezing, more intensive immune activation, were 3.6-fold more likely. It was as important a predictor as was hypertension, diabetes, high CRP. Now, the individuals who are at greatest risk for coronary disease as a function of allergy are younger individuals, particularly younger women. In older men, allergy was not a predictor. In younger men, wheezing was somewhat of a predictor. In older women, wheezing was a predictor, but in younger women, upper airway allergy and wheezing were strong predictors of risk of cardiovascular disease. Another study, the Army study, atherosclerotic risk factors in young male youngsters. Here we're going to look at 141 18-year-old men in Austria that were going to register for the armed service. Now, every young man in Austria must register for the armed service. We're going to exclude those with overt asthma because they would not be accepted for military duty. You're going to evaluate the rest for allergic rhinitis, runny nose, allergic rhinitis with additional asthma. You're going to look at their IgE levels. That is an antibody that is high in allergic conditions. You're going to look at standard risk factors. You're going to do a carotid artery IMT, and you'll define a high MT as above 0.8. We're going to look at IMT, which shows your predisposition to cardiovascular disease in relation to parameters of allergy, and you're going to correct for the standard risk factor. So you can look at the contribution allergy has on carotid IMT in these young people. Now, overall, 24% of the subjects had some sort of allergy or asthma, 19% of those with low IMT, but in those with high IMT, the prevalence of allergy was greater, 37%. Those with high IMT had higher IgE levels than those with low IMT. So young people with allergy are at an increased risk of cardiovascular disease. And again, allergy is inflammation, and it tends to be chronic. Of course, that's going to increase our risk for other inflammatory conditions like atherosclerosis. The Bruneck study looked at 826 40 to 70-year-old men and women residing in Bruneck, Italy. You're going to look for allergic disorders. 4% of them had an allergic disorder. Look at standard risk factors. Do a carotid ultrasound now and 5 years later. 390 of the 826 had progressed. They had new plaque or their plaque had progressed. Let's see if allergy status at baseline is predictive of who will and who will not have progression of their atherosclerosis fairly late in life, between ages 40 and 70. Now, overall, 4% had an allergic disorder. Those who progressed, 6.5. Those who did not progress, it was 1.5. Those who progressed had higher IgE levels. So allergic status is associated with an increased risk of cardiovascular disease or disease progression in 18-year-olds and in middle-aged individuals in Europe. Let's talk about endotoxin load and plaque progression. Endotoxin is the bacterial gram-negative bacteria cell wall is composed of lipopolysaccharide. It is inflammatory. If endotoxin is in your blood, that means that bacteria got into your blood. 516 subjects, 86 men and 86 women in their 6th through 8th decades residing in the same province in Italy. Record at baseline historical evidence of prior infection or current infection. You're going to measure blood endotoxin levels reflecting the level of abnormal bacterial activity in your blood. Smoking status, you're going to do a carotid ultrasound. You're going to repeat the ultrasound in 5 years looking for new atherosclerosis. You're going to correlate endotoxin level, smoking, and infection. Does this increase your risk of new plaque? Now, nearly all blood specimens contained endotoxin. We don't like to think about it, but we're teeming with bacteria. We've got bacteria in our gut, we got bacteria in our bladder, we got bacteria in our mouth. And if there's inflammation, such as gingivitis, these bacteria can kind of get in the blood. The median value is 14 with a wide range. Levels are higher in women and smokers. Why women? Recurrent urinary tract infection. Why smokers? Recurrent bronchitis. Now, you looked at a number of different risk factors and found the usual risk factors, hypertension, diabetes, smoking, etc., were associated with an increased risk of atherosclerosis. But endotoxin load was greater in those that developed new plaque than those who were stable. C-reactive protein was greater in those that developed new plaque versus those that were stable. We get CRP from many things. We talked about sleep apnea, overweight, chronic infection will also raise C-reactive protein. Now, here we're going to divide the individuals into terciles of endotoxin load, 10% brackets. And those in the upper tercile, the upper 10% for endotoxin, were at increased risk of developing new atherosclerosis. The risk was present in all of the subjects, but it was much greater in current and ex-smokers. The relative risk of having a high endotoxin burden was present in non-smokers it was greater in ex-smokers and the greatest in current smokers. Why? I believe because if you're a smoker, you're damaging your artery wall, heat shock proteins, you have these chronic infections, you're mounting an immune response to the heat shock protein that will cross-react against heat shock protein on your artery wall elicited by smoking. Remember, heat shock protein molecular mimicry. If we look at endotoxin load, we see that it's more of a problem in smokers and ex-smokers than in non-smokers. We can also look at infectious burden. The more infections you have, the greater is your risk, and that risk is amplified in the smokers. Same as with endotoxin, infectious history, it's a problem in everybody, more of a problem in smokers. Now, circulating bacterial endotoxin provokes endothelial dysfunction and circulatory inflammation. It will stimulate the toll-like receptor on our monocytes, macrophages, and T cells, cranking them up. It promotes abnormal blood clotting and plaque deposition, promotes the cardiac cells to commit apoptosis, suicide. Where are we getting this endotoxin? Chronic recurrent bacterial infections. Number one is gingivitis, smoker's bronchitis, gut barrier dysfunction, leaky gut from inflammation, and in heart failure, we'll talk about this later, the edema in the gut allows bacteria to leave the gut and enters the circulation. Genomic and acquired inflammation IMT. This is the Bolzano study again. You're going to look at their standard risk factors, and you're going to look at genomic variants that upregulate interleukin-6 function. And we all vary slightly in our DNA code. Our enzymes will have slightly different sequencing of amino acids. Some of us are really good at making IL-6, TNF, etc. And we're really good at responding to bacterial infection. And Mother Nature kind of likes that because when we were cave people, we did a lot of dying from infection. It's a problem today in that we're not dying of infection, but we're dying of atherosclerosis. So they looked at 3 alleles of interleukin-6 that cranks up the immune response. They looked for evidence of chronic infection and found that in a third of the patients, they did carotid IMT, and we're going to correlate these genomic differences with acquired inflammatory status, such as infection and your IMT. Now, 73% of the subjects did not have any of these IL-6 upregulations. 24% had 1, 3% had 2 or 3. The greater the number of IL-6 upregulations you had, the greater was your IMT. Because chronic inflammation, being really good at making IL-6, of course you're going to have more inflammation of lipids that are trapped in the artery wall, more oxidation, a more brisk Th1 and Th17 immune response. Now, the greater the number of genomic upregulations you have, the greater your IMT. But in non-smokers, the difference is fairly minimal, but it's magnified in smokers. Smokers have greater IMT than non-smokers. If you got the bad DNA, it's more of a problem if you're a smoker, because the smoker's causing inflammation leading to infection. And if you're genetically predisposed to an overly exuberant immune response, you're going to get more chronic inflammation. So smoking doesn't mix well with bad DNA. If you look at IMT as a function of none, 1, or 2 or 3 IL-6 upregulations, people that don't typically have chronic infections, it's not too big of a problem. If you're never exposed to bugs and you're really good at making IL-6, but you don't have any infections, it won't be a problem. But the more bugs you're exposed to, the more you upregulate IL-6, the more cardiovascular disease you're going to have. Some individuals were obese, others were not obese. They're, again, being overweight, having chronic infections doesn't mix well with bad DNA. The more opportunities you give your DNA to behave badly for you, the more it's going to hurt you. Number of inflammatory conditions, smoking, diabetes, obesity, or infection. Some had none, some had 1, some had 2 or 3. And again, you'll see the more exogenous or acquired inflammation, the greater is the plaque-producing potential increase related to pro-inflammatory DNA. So this interaction between allergy, infection, and genetics inflammation of any source increases IMT and increases cardiovascular disease risk. Where is this occurring in North America? Sleep apnea. Unfortunately, the environment is polluted with automobile exhaust. That initiates an immune response. Allergic disease, infection, acute and chronic, particularly periodontal disease, genetic predisposition to inflammation, powerful interaction between genetics, smoking, and infection. There's going to be some role for antibiotic therapy. We want to quell these infections, but a stronger role for general immune system support and supplementation. We will supplement you with nutrients to upregulate your physiologic immune response and with nutrients to downregulate the response when it's supposed to, because the more infections you have, the longer you mount an inflammatory response to infections, the more Th1, Th17, the more cardiovascular disease. That concludes this section, and we'll move on next to a discussion of the role of statins in heart failure. This section deals with the utility of statins, HMG-CoA reductase inhibitors, not in the treatment of atherosclerosis, but rather in the treatment of congestive heart failure. Now, statin drugs were developed to blunt the synthesis, the generation of cholesterol in the liver. They block an early step in the synthesis of cholesterol. Now, what exactly they're doing, they're blocking an enzyme that converts 2-carbon acetyl-CoA fragments into mevalonate, which normally would be converted to cholesterol and to other intermediates called isoprenoids. So essentially, when you're taking a statin, you're blocking cellular signaling. You're blocking farnesylation and granulation of signaling proteins RAC, Rho, Rab, and P-laminin. And I love saying that. We're blocking granulation of RAC, Rho, Rab, and P-laminin. And these are mediators of inflammatory and immune signaling. So when you take a statin, yes, you are blocking the generation of cholesterol in the liver, but where you're really having an effect is downregulating the immune and inflammatory response. Now, there's something to be said for having lower levels of LDL cholesterol. If your cell membranes are full of cholesterol and saturated fats, they won't function well, and you'll have trouble with cell membrane function. You'll have trouble making nitric oxide. But really, what we want to do with statins is lower inflammation. Statins will blunt the generation of free radicals by many of the enzyme systems found in the artery wall. The generation of superoxide by an enzyme called NADPH oxidase, a key contributor to intimal free radical inflammation, is blunted by statin therapy. If we have an antioxidant effect by blunting the generation of free radicals, we're going to blunt LDL oxidation. We're going to improve endothelial function. We're going to downregulate a host of inflammatory mediators pertaining to the immune system. We're going to blunt oxidation. We're going to blunt oxidation of LDL. We're going to decrease a lot of Th1 activities. Immune cells are less efficient at presenting snippets of oxidized LDL to T lymphocytes. CD40 ligand signaling, we talked about that as a predictor or a mediator of restenosis following angioplasty. That's downregulated by statins. The toll-like receptor is downregulated, so the whole immune system begins to stand down a little bit. We see greater levels of regulatory cells and lower levels of CD28 null cells and Th17 cells. Remember, statin therapy improved outcome in the patients that had the greatest degree of immune system upregulation. If your immune system is not active, it's quiescent, statin therapy is not as important for you. Now, we appreciate the benefits of statins in atherosclerosis. Well, what about the use of statins in congestive heart failure? Well, at first, this doesn't seem like a really good idea. Here was a study of just over 1,000 patients with ischemic or non-ischemic heart failure. They had class 3 to 4 symptoms despite drug therapy with ACE inhibitors, digoxin, and diuretics. Class 1 means you can play tennis without any trouble. Class 2 is you're having shortness of breath climbing stairs. Class 3 is symptoms with usual activity. Class 4 is symptoms at rest. Their average ejection fraction was 21%. This was not a randomized double-blind study. It was a retrospective analysis of another trial of calcium blockers, another class of drugs in heart failure. Now, 12% of these patients with heart failure received a statin at the discretion of their doctors. Those who received a statin were more likely to have high cholesterol or coronary disease than those that did not. Their doctors weren't giving them statins to deal with heart failure. They were giving them statins to deal with coronary disease and hyperlipidemia. And you follow these patients for 15 months. Now, will statin therapy be beneficial? Well, at first blush, you would think that statin therapy in heart failure would be a bad idea. First of all, no FDA safety studies of statins have been done in individuals with pump dysfunction or heart failure. Statins, as a byproduct of their metabolic activity, will lower levels of coenzyme Q10 and testosterone. Now, CoQ10 and testosterone are good in heart failure. They are wasted by statin therapy. And as a general rule, the lower your cholesterol, the greater is your mortality risk with heart failure. People with heart failure and high cholesterol do better than people with low cholesterol. Why? One of cholesterol's jobs is to sop up bacterial lipopolysaccharide. Also, cholesterol is an antioxidant. Free radicals will oxidize cholesterol and LDL, but that serves to quench free radicals. So as heart failure is associated with free radical stress and bacteremia, high cholesterol is actually protective. So lowering cholesterol with statins would seem kind of like a dumb idea. Well, what happened in these patients? They did much better. Mortality was less with statin therapy. There was a 62% reduction in death rate, 12 versus 31 deaths per 100 patient years. That's one fewer death for every 5 patients treated with a statin. That's a very powerful therapeutic effect. Now, total mortality was decreased by 62%, sudden death by 57%, death due to heart failure, pump failure by 70%. Now, historically, the lower the cholesterol, the worse you do, but not with statin therapy. Lowering cholesterols with statins had a beneficial effect. Well, why? This led to a randomized double-blind study. 63 patients with non-coronary dilated cardiomyopathy. They had significant symptoms, they had pump dysfunction, they're on standard drug therapy. You do a baseline assessment, randomize them to receive simvastatin, 10 milligrams a day. That's a fairly low dose of simvastatin. You can go up to 80 milligrams for placebo. You're going to reevaluate it 14 weeks. It was a double-blind protocol. Neither the physicians rating the patients nor the patients knew whether they were getting placebo or they were getting simvastatin. Tumor necrosis factor alpha rose over 3 months with placebo therapy, as you would expect. It fell slightly with simvastatin. Interleukin-6 fell. Flow-mediated vasodilatation, a measure of endothelial function, improved with statin therapy. BNP, the cardiac marker of stress or strain, fell, while it rose with placebo therapy. Ejection fraction rose minimally with placebo therapy. It rose considerably from 34% to 41% with statin therapy. Functional class improved in a fraction of patients with placebo therapy and in 40% of the patients receiving statin therapy. So in this randomized double-blind study, statin therapy was helpful. Well, should we treat our heart failure patients with statins? Well, it's physiologically sensible because just as statins will downregulate the Th1 T17 to Treg imbalance that drives forward atherosclerosis, it does the same thing with congestive heart failure. So now that we understand these immune mechanisms of atherosclerosis and heart failure, yeah, it makes sense that statin therapy would be helpful. Statins are cheap. They cost $2 a month. Why not use them? Now, statins do have a downside. They waste coenzyme Q and testosterone. Well, we'll supplement you with coenzyme Q10, and if you're a man, we'll give you testosterone. We're going to give you the good and mitigate the bad. Questions: what's the optimal dose of a statin? It seems like a low dose will get the job done, quieting down the immune system. Will there be long-term side effects of immune system suppression? If we suppress this deleterious immune response, will we also suppress the appropriate immune response to cancer or real infection? It turns out that does not occur. Our immune modulator therapies, they downregulate an inappropriately upregulated immune response, but they tend not to suppress our healthy or innate immune response. We're not seeing more cancers in the future in people that are receiving statin therapy. Red yeast rice extract is a green statin. It's a botanical statin. It will lower cholesterol. It will lower CRP. It tends to provide the same immunomodulation effect as does statin therapy. We use it in cardiovascular patients who cannot take statins, who do not wish to take statins. Will red yeast rice have the same benefit in heart failure? It hasn't been studied yet, but logically we would expect that's the case. So this is a brief discussion of statins in heart failure. They work by modulating the upregulated Th1, Th17, low Treg status associated with heart failure. Now we'll move on to the last section of DVD2, where we'll have a discussion of nuclear factor kappa beta, a master transcription factor, external counterpulsation, and blockade of the renin-angiotensin II system with pharmacologic therapy. DVD 2 of our presentation, Immune Mechanisms in Cardiovascular Disease, concludes with this discussion of nuclear factor kappa beta, enhanced external counterpulsation, and blockade of the renin-angiotensin II system. 15 years ago, we introduced enhanced external counterpulsation in Northwest Ohio. We were the second practice in the state and the 22nd in the United States to provide our patients with ECP. It was presented as an alternative to angioplasty or bypass surgery in individuals who had narrowings not amenable to those methodologies. So if you were too far gone for balloon angioplasty or bypass, we still had something that we could offer you. Now, in the United States, if you have single vessel coronary disease, one blockage, we're going to treat you with a percutaneous intervention, balloon angioplasty or stent. The balloon catheter is placed across the narrowing, the balloon is inflated, a stent will be placed. Wow, plaque's gone, blood flow's normal, you're good to go. If you have multi-vessel coronary disease, we would be concerned that if we tried to stent all three arteries, if one went bad, you'd have a big problem. So if you have multi-vessel disease, you're going to undergo coronary artery bypass surgery or CABG. Vein grafts will be removed from your legs, tied into the aorta, and then sewn into the artery beyond the blockage, bypassing the blockage. Whenever possible, surgeons will use the left or the right internal mammary artery that serves the chest wall. The chest wall gets blood from below, and these grafts are more durable than vein grafts. Half the vein grafts fail at 7 years, while 9 out of 10 internal mammary arteries will be open at 10 years. So those bypass grafts resist atherosclerosis. Now, let's say you can't undergo a bypass or a balloon, then we would treat you with ECP, thinking that ECP will generate natural bypasses or collaterals. Now, with ECP, we put large pneumatic cuffs over your lower extremity, and in sequence to your heart rhythm, we will inflate the cuffs, 1, 2, 3, and generate a retrograde pressure wave to drive oxygenated arterial blood into the arteries under pressure. Then when the heart's getting ready to beat again, we deflate the cuffs so the heart is ejecting into a dilated system, into a vacuum. This unloads the heart, lowers its workload. We call this afterload reduction. So during ECP, we are going to lower the systolic pressure and raise the diastolic pressure. Now, the heart receives its blood in diastole between beats. So if we lower the cardiac workload and shunt blood back to the heart when it's open and ready to receive it, we're going to shunt that blood through our collaterals, enlarge them, and you'll be left with an enhanced collateral system. This is a patient with good augmentation. We raised the diastolic waveform. This is a patient who had previously undergone metal detoxification. He had elastic arteries. He had fantastic augmentation. We treated him approximately 15 years ago. He has multivessel disease, one artery open. We treated him 15 years ago. We've treated him intermittently and used many of our other therapies. He's still with us. He's still doing great. Post-ECP, we see elaborate natural bypasses. So you can have one closed artery or one patent graft, and if we can treat you with ECP and generate natural bypasses, you'll do pretty well. And your nuclear stress studies will improve. So we felt that ECP was effective in controlling angina. But as we gained more experience with ECP, we saw that patient outcomes were improving. When we looked at my first 181 patients and we looked at event rate in the 2 years preceding ECP versus event rate in the 2 years post-ECP, these patients were doing a lot better. Now, these were patients that were in and out of the hospital a lot with their inoperable angina. 81% had had some sort of event before ECP, 2 years post, only 22%. So we were controlling their symptoms, and it also appeared we were having a favorable effect on their outcome. This was my experience and the experience of the other ECP practitioners in the United States. Well, what's going on here? Are we doing more than generating collaterals? It turns out ECP provides an antioxidant effect. Well, if we have an antioxidant effect, we're going to downregulate the immune response. We're going to block LDL oxidation. Here we're going to measure malondialdehyde levels. This is a marker of oxidized phospholipids. Remember, the phospholipids of the LDL get oxidized first and the protein later. So we're going to measure malondialdehyde in 35 healthy volunteers, 69 coronary patients. Then we're going to randomize them to 7 weeks of medical therapy or 7 weeks, 35 hours of ECP. Now, our coronary patients have higher levels of malondialdehyde than do controls, as you would expect, oxidative stress. 7 weeks of medical therapy doesn't have an antioxidant effect. Malondialdehyde doesn't fall. With ECP, it falls. So with ECP, we're providing an antioxidant effect. Nitric oxide. Endothelial cells convert arginine from our diet into nitric oxide. Nitric oxide is the most important molecule in the cardiovascular system. It maintains the vasodilatory tone of our arteries. It inhibits platelet activation and clotting. If we make lots of nitric oxide, our endothelial cells do not elaborate chemotactic factors for monocytes or adhesion molecules for monocytes. They resist infiltration of smooth muscle cells into the artery wall. So we want to see a lot of nitric oxide. Nitric oxide levels rise with ECP. Endothelin is sort of a bad guy cytokine elaborated by a diseased artery wall. Endothelin levels fall. So we're improving arterial wall biochemistry, improving nitric oxide generation with the ECP. Endothelial function, the ability of the artery to dilate in response to a physiologic stimuli, is the most important determinant of who's going to do well and who's going to do poorly. Here we have a study, patients with chronic angina, abnormal angiograms, abnormal stress nuclear studies, poor endothelial function. You're going to treat them with ECP. Flow-mediated vasodilatation should be about 10 to 12%. It was 4% pre-treatment, as you would expect. Post-ECP, it normalizes. So we're having a fairly powerful biochemical effect. Now, nuclear factor kappa beta, we've touched upon this as a Th1 mediator. Nuclear factor kappa beta, present in our immune system cells, is an amplifier of inflammation. We have a number of threat receptors on the cell membrane of our immune cells, such as the toll-like receptor. There are many others for different cytokines, such as tumor necrosis factor. When these receptors are ligated, activated by their corresponding inflammatory molecule, they activate an enzyme called MAPK, mitogen activated protein kinase. And what it does, it stimulates an enzyme called inhibitor of kappa beta kinase. Now, nuclear factor kappa beta is jailed in the cytoplasm by its inhibitor. and it won't cause inflammation if it's jailed by its inhibitor. When the cell senses distress and MAPK is activated, it will activate the enzyme that will degrade the inhibitor. Then nuclear factor kappa beta can enter the nucleus of the cell where the DNA is. It binds to its co-activator and an enzyme called RNA polymerase, which helps it read DNA, and it starts to code for proteins involved in inflammation, such as C-reactive protein, interleukin-6, tumor necrosis factor alpha. So all these threat signals cause nuclear factor kappa beta to translocate from the cytoplasm to the nucleus, and then a lot of bad stuff happens. Here's a diagram of nuclear factor kappa beta interacting with RNA polymerase, opening up the DNA and coding inflammatory mediators. Now, let's look at the state of nuclear factor kappa beta activation in stable versus unstable angina. Ask yourself, who's going to have the highest levels of nuclear factor kappa beta? Unstable angina with an upregulated immune system or stable angina with a quiet immune system? Let's see. 102 consecutive patients undergoing heart catheterization, 19 with unstable angina, 83 without unstable angina. Some had coronary disease, some had valve disease, some had heart failure, some had non-coronary chest pain. And then as a control group, we've got 29 patients without cardiovascular disease, without infection or inflammation. And we're going to look at activation of the nuclear factor kappa beta pathway. Now, individuals with unstable angina, of course, have much higher levels of nuclear factor kappa beta than those with stable angina. The reason they're unstable is their immune system was activated, and as a mediator of immune activation, we have activation of nuclear factor kappa beta. That makes a lot of sense. Now let's look at nuclear factor kappa beta activation in stable versus unstable plaque. The preceding study looked at NF-kB in the circulation. Now we're going to look at plaque. 32 patients undergoing coronary atherectomy, so you can scoop out the plaque and look at it under the microscope. Half had unstable angina, half had stable angina. Now, the dominant lesion, the dominant histology of the stable plaques was dense fibrous tissue, a lot of collagen, a lot of smooth muscle. Those with unstable angina had less smooth muscle, less collagen. It had been degraded by matrix metalloproteinases released by these activated macrophages, and it had more of a cellular infiltrate, T cells, macrophages, and an atherosclerotic rule. That would make sense. If we look at the activity of nuclear factor kappa beta, it was of course greater in those with unstable angina versus stable angina. If you look at ICAM, that is a monocyte adhesion molecule elaborated by the endothelium in response to inflammation. That protein, by the way, is uncoded by nuclear factor kappa beta. Of course, it would be higher, reflecting upregulation of nuclear factor kappa beta. Now, atherosclerotic lesions are focal. When I first got involved in cardiology, I had this question: if we've got this atherosclerosis, why aren't all of our arteries diffusely narrowed? And why do some people have blockages in their heart and not their brain, and vice versa? And we do know that most of our blockages don't occur on a long tubular region of the artery, but they occur beyond branch points, where flow is less laminar and it's more turbulent. You know, when a river forks, on the branches you'll see flotsam and jetsam and all this other debris, which is pushed against the banks because flow is not uniform. The same thing is happening in our arteries when they branch. Now, let's look at the effect of ECP on vascular inflammation. 35 domestic male pigs. You're going to randomize them to receive a specific diet for 15 weeks. One group gets standard pig chow, which is low in oxidized cholesterol. Another group receives an atherogenic diet, rich in cholesterol and antioxidants. And you know that this diet will produce atherosclerosis in these pigs. Now, at 8 weeks, you're going to divide the high cholesterol pigs into two groups. One group gets external counterpulsation 2 hours a day, every other day for 34 hours. How you convince a pig to undergo ECP, I got no ideas how they do that, but they did it. and another group didn't get ECP. At 15 weeks, you're going to sacrifice the animals and look at the artery wall. Now, cholesterol levels were low with Purina pig chow, but in the high cholesterol animals, the cholesterol rose with the atherogenic diet. Now, at 8 weeks, one group received ECP, and in that group, the cholesterol level fell a little bit. It wasn't statistically significant. The investigators didn't comment on it, but I thought that was interesting that ECP tended to lower cholesterol. Now, mean arterial flow velocity, mean arterial shearing stress was increased with ECP. With ECP and with exercise, if we increase laminar pulsatile flow in our arteries, we will increase shearing stress. Now, atherosclerosis is initiated in these branch points at areas of low shear stress. So we're going to treat these arteries with ECP and we're going to increase shear stress. Shear stress stimulates the artery wall to make nitric oxide and to have an antioxidant effect and to improve endothelial function. We've demonstrated that in humans with ECP. So we're going to apply ECP to these pigs with a early atherosclerosis, increase shearing stress, and see what effect that will have on the development of atherosclerosis in response to a high oxidized cholesterol diet. Now again, they didn't have blockages that were collateralizing. They had early diet-induced atherosclerosis. Can we influence that with the ECP? Well, here are the pigs that received normal chow. They had very little plaque. In red is plaque. Being in the high cholesterol diet, you can see they have more visible plaque. Microscopically, they've got a lot of plaque. The animals on the high cholesterol diet that were co-treated with the ECP, they got less plaque. You don't see as much macroscopically, you see less under the microscope. So diet-induced atherosclerosis in pigs was attenuated by ECP. This is a scanning electron micrograph of the vessel wall. These are the endothelial cells, individual endothelial cells. These little bumps here are monocytes adhering to the endothelial surface. They're going to infiltrate the artery wall and become macrophages that will oxidize and gobble up the LDL. They are sticking to the artery wall in these locations because the artery wall is elaborating adhesion molecules, VCAM and ICAM, in response to inflammation. So the high cholesterol diet, inflammation, you have VCAM being expressed by the endothelial cells. Yep, the white cells are going to bind to that and enter the artery wall. This is blunted with ECP. So you have less immune cell infiltration in the artery wall in the high cholesterol pigs that were treated with ECP. Macrophage positive areas, of course, you're going to see a lot of macrophages in the hyperlipidemic animals. Those treated with ECP, there's less macrophage infiltration because there's less inflammation, fewer chemotactic molecules, fewer adhesion molecules. Complement is a protein that's involved in immune-mediated damage. You see a lot of that in the hyperlipidemic pigs. It is attenuated with ECP. CRP is made by the liver in response to systemic circulation. CRP is made by immune cells in the artery wall in response to hyperlipidemia, lipid oxidation, and inflammation. You see a lot in the hyperlipidemic pigs. There's attenuation with ECP. Mitogen activated protein kinase, that is the enzyme that transduces threat at the level of the cell membrane towards moving nuclear factor kappa beta out of the cell fluid into the nucleus, where it's going to code for the formation of inflammatory mediators. It is blunted with ECP. If we look at how much nuclear factor kappa beta is in the cells, hypercholesterolemia raises it sixfold. That is blunted with ECP. If we look at the inhibitor of nuclear factor kappa beta, that is reduced with hyperlipidemia. It is more than normalized with ECP. Now, this is a histological slide. In green is nuclear factor kappa beta. In red is the nucleus. And in the normal situation, all the nuclear factor kappa beta is green. It's staying out of the nucleus. With the hyperlipidemia, you have activation of the threat pathways, the nuclear factor kappa beta translocates into the nucleus. You see all this yellow because the nuclear factor kappa beta got into the nucleus. If you treat them with ECP, that is prevented. So ECP, with this shearing stress that we apply, is blunting this pathway through which all threat receptors at the cell membrane lead to nuclear factor kappa beta translocation of the nucleus and the transcription of all these inflammatory mediators. Thus, ECP has a direct anti-atherosclerotic effect. This is why my patients are doing so well. We've actually influenced the course of their atherosclerosis with ECP because we were blunting their atherosclerosis. This is a really cool concept. Now, this was a pig model. What happens in humans? 21 consecutive patients referred for ECP, all with persistent angioedema coronary disease, do the baseline lab studies, randomize them to receive 7 weeks of standard ECP where we apply a lot of pressure. Another group got sham ECP. Enough pressure was applied to blow up the balloons, but it didn't have a biological effect. Now, the patients didn't know what they were supposed to experience, so they didn't know if they were getting real or fake ECP. Then you're going to repeat the lab studies. Tumor necrosis factor alpha rises slightly during sham therapy. It falls with ECP. Monocyte chemotactic protein 1 that pulls white cells into the artery wall falls. And the clinical effect of real ECP, anginal episodes per day falls from 1.6 to 0.4. Functional class improves, just as has been our experience with the ECP. So we improve your functional status, and we're having an anti-atherosclerotic effect. One of the reasons we're having an anti-atherosclerotic effect is we're improving endothelial function. If you scrape off the thin layer of endothelial cells from all of our arteries, you're going to have a massive tissue the size of the liver. So the endothelium is really an endocrine organ releasing vasoactive molecules such as nitric oxide. You got a lot of nitric oxide, you're going to resist atherosclerosis. We make that with ECP. Now, there's a lot of biochemistry going on in the endothelium, and we have another presentation on endothelial function, but the key reaction is the conversion of arginine into nitric oxide. So we will give you arginine and cofactors such as methylfolate, so you turn all your arginine to nitric oxide. If you don't make nitric oxide, you're going to make superoxide a free radical and you're going to get atherosclerosis. Another key reaction is the conversion of angiotensin 1, a relatively weak vasoconstrictor, into angiotensin 2, a powerful vasoconstrictor and cause of endothelial dysfunction by an enzyme called ACE, angiotensin converting enzyme. It has another activity, and here it goes by another name, kinase 2, that degrades bradykinin into active peptides. Bradykinin is a good guy. It helps us make nitric oxide and prostacyclin, a vasodilating prostaglandin. So this enzyme is a problem. We see high levels in people in the circulation, people with high blood pressure. So you're going to convert your angiotensin 1 into the vasoconstrictor angiotensin 2, and we see high levels in the artery wall of individuals with atherosclerosis. Now, how does this all work? Angiotensin 1 is made in the liver in response to interleukin 6, just like C-reactive protein. The more inflammation, the more angiotensinogen. Now, angiotensinogen made by the liver is relatively inactive. Renin, made by the kidney in response to stress or poor blood flow or heart failure, converts angiotensinogen 1 into angiotensin 1, which is a very weak vasoconstrictor. Angiotensin converting enzyme converts it to angiotensin 2, which is a powerful vasoconstrictor. It then goes to the adrenal gland and stimulates the release of aldosterone, which causes sodium and water retention. So when this pathway is upregulated, we have high blood pressure and a tendency to fluid retention and heart failure. This is a big problem. So we may treat you with drugs that block ACE. So we'll blunt the conversion of angiotensin 1, which is benign, into angiotensin 2, which is a real problem. So we will treat you with ACE inhibitors. The first ACE inhibitor, captopril, came out when I was a third-year medical resident. And back then, our therapies for hypertension were very limited. Nothing worked very well. And this was a huge breakthrough and allowed us to lower blood pressure in individuals with previously refractory hypertension. And this had a great benefit in the outcome of patients with hypertension and heart failure. And after a while, we learned that our patients were improving above and beyond the benefit we would expect from blood pressure control. We appeared to be having in some patients with certain ACE inhibitors a benefit with respect to atherosclerosis. So the question is this ACE that we want to inhibit present in the circulation, or is it also present in the circulation and in the tissue, such as the heart and the artery wall? Well, it turns out that 90% of the ACE in our body is in the tissues. The lion's share is in the artery wall, where if it's upregulated, it causes inflammation within the Th1 and Th17 pathways. Here we're going to take 53 patients undergoing atherectomy. You're going to take a plaque specimen. 36 have stable but persistent angina with stable plaques. 17 have red hot, unstable angina, a non-Q wave infarction or unstable angina. So they're going to have immune upregulation, a lot of Th1, Th17, low Treg activity. And you see that those with stable angina have low levels of ACE in the artery wall. Those with unstable inflammatory angina have a lot of ACE. So tissue ACE is a big problem. So if we're going to give you an ACE inhibitor, I want to give you a lipophilic, a fat-soluble ACE inhibitor, such as quinapril or ramipril. It will lower your blood pressure, but it also gets into the artery wall and into the heart cells and has powerful anti-inflammatory activity. These drugs, if we give them to people that don't have cardiovascular disease, will decrease your risk of new onset cardiovascular disease. That was the HOPE study. The Quo Vadis study took people undergoing open heart surgery and gave them placebo or quinapril on top of standard therapy. At 1 year, there was an 80% reduction in post-bypass event rate. It blunted their atherosclerotic diathesis. In one study looking at patency post-angioplasty or stent, quinapril showed a benefit. The ACE inhibitors that don't get into the artery wall don't have these benefits. So if you're taking a non-lipophilic ACE inhibitor like enalapril or captopril or lisinopril, I want you to switch to one that gets in the artery wall, such as ramipril or quinapril. Now, these agents are off patent. They're still a little bit more expensive than the old-fashioned ACE inhibitors, but it's worth spending just a few dollars more a month to block ACE in the artery wall. So this is a pretty much universal recommendation if I'm going to use pharmacologic therapy in my patients with heart failure or coronary disease. Now, so we can give you an ACE inhibitor that gets into the artery wall to block the conversion of angiotensin 1 into angiotensin 2. But that may not get the job done. Now, this angiotensinogen, made in the liver in response to inflammatory mediators, it can diffuse into the artery wall where tissue proteases have a renin-like effect. They'll convert it into angiotensin 1. Now, we can block the conversion of angiotensin 1 into angiotensin 2 with an ACE inhibitor that gets in the artery wall, but there are other inflammatory enzymes present in the artery wall released by upregulated immune cells that will convert angiotensin 1 into angiotensin 2. So ACE inhibitors alone will not totally block the production of angiotensin 2. And we want to do that because there's an angiotensin receptor in all of these cells of the vascular wall. And what does it do? It mediates threat, and it causes nuclear factor kappa beta to translocate in the nucleus and start cranking out those inflammatory mediators, such as interleukin 6, C-reactive protein, tumor necrosis factor. Now, this interleukin 6 will leave the artery wall, go back to the liver. It'll make CRP and more angiotensinogen, more fuel for the fire. With activation of nuclear factor kappa beta, we get a lot of free radicals, more LDL oxidation, more chemotactic and adhesion molecules, so the atherosclerotic process is activated. So we may want to use angiotensin receptor blockers. These are called ARBs. They don't block the conversion of angiotensin 1 and angiotensin 2. They block the angiotensin 2 receptor. So any angiotensin 2 you got will not stimulate the generation of inflammatory mediators. So let's look at the potential benefits of angiotensin receptor blockade in patients with unstable angina. We're going to look at their CRP levels. 25 patients admitted to the hospital with unstable angina. all receive standard medical therapy, aspirin and Plavix, which is our most powerful antiplatelet agent. They get a beta blocker, they get a statin, and you randomize them to receive an angiotensin receptor blocker, an ARB. This is irbesartan, and its trade name is Avapro or placebo. And then you look at C-reactive protein levels, they fall slightly from 2.5 to 2.3 at 4 weeks with placebo therapy. They fall a lot more from 3.1 to 1 with angiotensin receptor blockade therapy. We block that inflammation in the artery wall, less interleukin-6 to go to the liver, less C-reactive protein. That makes a lot of sense. Let's talk about the use of angiotensin-converting enzyme inhibitors and or angiotensin receptor blockers. We'll call those blockers of the renin-angiotensin II system, plus or minus aspirin on Th1 expression. 68 patients undergoing carotid endarterectomy, they all have at least a 70% narrowing, so you're going to scoop out the plaque and look at it. 36 have symptomatic disease. Their plaques are activated, they're inflamed. 17 have slowly progressive but still asymptomatic disease. Those are going to be stable, fibrous plaques without immune system upregulation. Now, they looked at their medical therapy over the 4 weeks preceding the atherectomy. 27 were on aspirin, 7 were on an ACE inhibitor and ARB, 20 were on both, 10 were on neither. You're going to analyze plaque specimens for nuclear factor kappa beta activity, CRP activity, correlate these markers of plaque immune activation with their clinical presentation and whether they took aspirin or a renin-angiotensin II system blocker. Nuclear factor kappa beta activity was greatest in the individuals that were not taking either drug. It was blunted by those that were on angiotensin converting enzyme inhibitor therapy or angiotensin receptor blockade. Aspirin had some effect, there was really no synergy. If we look at CRP activity, neither blockade of the angiotensin II system or aspirin had an effect, but if you took both, there was a synergy. There are multiple immune pathways, and we can use different drugs and different nutritionals to target some but not all. So, of course, we're not surprised to see a synergy like this. Now, we show that these agents would lower nuclear factor kappa beta and or CRP, and let's look at the symptomatic status of the patients. Those who were negative had low levels of nuclear factor kappa beta activation. The majority of them were asymptomatic, whereas those that were positive for nuclear factor kappa beta, inflammation, Th1, Th17, they were more likely to be unstable. Why are they unstable? Because they had immune system upregulation, and one of the meteors of that is nuclear factor kappa beta. That makes sense to us. Now let's look at blockade of the angiotensin II receptor and matrix metalloproteinase activation. 70 hypertensive patients with symptomatic high-grade carotid narrowings, you're going to randomize them to receive an angiotensin receptor blocker, Avapro, or a diuretic, chlorthalidone. Now, chlorthalidone simply is a water pill. It has no immune effects. Avapro blocks the angiotensin II receptor in the circulation in the arteries. All undergo carotid surgery 4 months later. We're going to analyze plaque specimens removed at the time of the surgery. Now, what effect did the drugs have on angiotensin II levels? None, because we're not blocking the conversion of angiotensin I to angiotensin II, so we wouldn't expect either drug to have an effect. If we look at levels of angiotensin I receptors, there's no effect. Again, we're not blocking the generation of the angiotensin receptor. If we look at levels of angiotensin II receptors, they're increased if we block the angiotensin I receptor. Our cells have two types of receptors for angiotensin II. Type 1 that mediates inflammation, type 2 that mediates anti-inflammation. The drug blocks only the bad guy, the type 1 receptor, and will upregulate the good guy, the angiotensin II receptor. Now, in response to stimulation of the angiotensin II receptor with angiotensin II, two enzymes are upregulated. cyclooxygenase 2 and prostaglandin GE synthase. Now, these are inflammatory enzymes. Remember how we talked about how phospholipases will snip a fatty acid from phosphatidylcholine. And if that fatty acid happens to be arachidonic acid, because our diet is high in meat and dairy, that's kind of a problem. It's a problem in the arteries. So here we've got this arachidonic acid that enters the prostaglandin pathway, causing bad prostaglandins and leukotrienes that cause inflammation and immune system upregulation. So the enzymes that convert arachidonic acid into matrix metalloproteinases are downregulated if we block the angiotensin receptor. If you have a lot of angiotensin 2 stimulating its receptor, those enzymes will be upregulated and you're going to make more matrix metalloproteinases. That's the theory. In practice, you see, if we block the angiotensin 2 receptor, we have lower levels of cyclooxygenase, prostaglandin E synthase, and thus we have less matrix metalloproteinase 2 and 9. And you can stain for these and see with the diuretic, you got a lot of these matrix metalloproteinases, they're blocked if we give you the angiotensin receptor blocker. Now, these matrix metalloproteinases are bad guys. They're the ones that degrade the fibrous plaque and cause your plaques to activate. So ARB therapy is going to quiet down the plaque and make it less likely to activate and rupture and cause a TIA or a coronary event. So there's less plaque matrix metalloproteinase production. You will also see a general downregulation in Th1, Th17 immune function, lower levels of lipid in the plaque, more smooth muscle cells, more collagen. The plaque will be less vulnerable. The fibrous cap will be intact. The plaque will be more stable. We will see fewer macrophages, fewer T lymphocytes, fewer immune cells presenting snippets of oxidized LDL to the immune system. So there's a generalized downregulation of the deleterious immune response of atherosclerosis with these agents that block the angiotensin 2 receptor. If we look at the generation of oxidized LDL within the artery wall, we want to block that, don't we? And we can block it with this agent. So these drugs have powerful antioxidant and immune modulating effects. They're relatively free of side effects and they help blunt this vicious cycle. Now, will these agents be additive to statin therapy? Statins downregulate the immune system. Aspirin non-specifically lowers inflammation. Will adding these drugs to a statin have a synergy? 112 patients with stable coronary disease, all on aspirin. None were hypertensive. So the traditional indication for ACE inhibition or ARB therapy was not there. None of them were on statin therapy. So you do baseline labs, and they all receive atorvastatin, Lipitor, and you're going to aim for an LDL of 100. That's kind of the standard of care. We're going to give you Lipitor, we're going to lower your LDL. 4 months later, even though they don't have high blood pressure, they're randomized to quinapril, which is a tissue-specific ACE inhibitor. It'll block the generation of angiotensin 2 within the artery wall, or Erbistat, which will block the angiotensin 2 receptor within the artery wall, or placebo. And you're going to repeat the lab studies. And of interest, if your blood pressure is not elevated and we give you these drugs, your blood pressure doesn't really fall much. So if you're hypertensive and you have vasoconstriction, your blood pressure will fall. But if your blood pressure is normal, we're not going to bottom you out with these drugs. Now, if we look at monocyte adhesion, and we don't want to see that, that was lowered with atorvastatin. Well, that's okay. We know that atorvastatin blunts Th1 and Th17. So now we've got all these people on atorvastatin, Lipitor, and then we treat them with placebo, and we see no real effect, no further effect on monocyte adhesion. But if we treat them with either quinapril or Erbistat, there's a synergy. There'll be lower levels of adhesion molecules, so white cells, monocytes, are less likely to adhere to the endothelial surface with a statin, and we can synergize by blocking the generation of angiotensin 2 or blocking its receptor. Interleukin-6 falls with atorvastatin. It falls further with quinapril or erbistatin. So indeed, there's a synergy. Let's look at angiotensin receptor blockade effects on vascular oxidative status. 47 stable coronary patients. They're all on aspirin. 90% are on a statin. None are hypertension. None have been on an ACE inhibitor or an ARB. All with prior revascularization. Do baseline labs. Treat them over 12 weeks with erbistatin, an angiotensin receptor blocker. Repeat the lab studies periodically. Neutrophil superoxide generation. We don't want a lot of superoxide. It's a cause of oxidative stress and LDL oxidation and phospholipid oxidation. It doesn't change with placebo. It falls with ARB therapy. How long it takes to oxidize your LDL is prolonged with angiotensin receptor blocker therapy. T-bars is a marker of lipid peroxidation, free radical stress, kind of like malondialdehyde. It falls with ARB therapy. Monocyte binding to the artery wall falls. All positive findings. Let's look at ARB effects in 33 relatively young, age 41 to 59 individuals with coronary disease. All with prior revascularization, none were hypertensive. We're going to do baseline labs, treat over 24 weeks with losartan and ARB, starting at 75 milligrams a day if your blood pressure was low, 150 milligrams a day if it was borderline elevated. We're going to repeat the lab studies periodically. We're going to have comparison labs from a control group of age-matched healthy controls. And again, if we give you losartan and your blood pressure is not high, it doesn't really fall much. Nobody bottoms out. Nobody got symptomatic hypotension. VCAM1, an adhesion molecule, this is the coronary patients at baseline. These are the normal controls at baseline. By blocking the angiotensin receptor within the artery wall, you can see that the VCAM levels normalize. Tumor necrosis factor receptors, that is another marker of TNF, it normalizes. Superoxide generation by the enzyme systems within the artery wall, within the circulation, also falls. So we're having a profound antioxidant effect by blocking the generation of free radicals. Now, will statin therapy, which lowers the generation of free radicals, synergize with angiotensin-converting enzyme inhibitor therapy, which also blocks the generation of free radicals? Would this be synergistic in people experiencing the intensive free radical stress of off-pump coronary bypass surgery? Here you have 22 stable coronary patients that are undergoing bypass surgery, and you randomize them either to continue their standard therapy. They were receiving relatively low doses of statin and a low dose of ramipril, or switch them to high-dose therapy. You're going to crank up their lipid-lowering therapy doses and their ACE inhibitor doses. You're going to do the bypass surgery 20 days later, and you're going to monitor cytokine levels post-op. Now, when you have open heart surgery, your heart is arrested, it's put on ice, but still, for a period of time, while the surgeon is placing the bypass grafts, your heart will be starved of oxygenated blood. So a lot of free radical mediators will accumulate. You're going to run out of antioxidants, but you're not making too many free radicals because you got no oxygen to use to make free radicals. Then when the surgery is over and the heart is started again, this heart, which now has no antioxidants, is exposed to oxygen and it generates a free radical storm. So there's intensive inflammation in association with off-pump open heart surgery. Now, what you'll see in the individuals with standard therapy, they have low levels of tumor necrosis factor alpha before surgery. 10 minutes later, there's a big spike, and it takes a while to fall. Those that were receiving higher doses of statins, higher doses of ACE inhibitor to blunt these enzymes that cause free radical stress, you don't see the spike in TNF. Same situation with interleukin-6. With low-dose therapy, there's a big spike that slowly returns back to baseline. It's not even back to baseline at 24 hours. With high-dose therapy, there's less of a spike. Inflammation like this leaks out into the entire circulation, and much of the morbidity of open heart surgery is other organs being affected by this free radical stress, the brain, the lungs, and the kidney. Thus, when you're undergoing open heart surgery today, you're going to be pre-treated with these drugs to blunt the Th1, Th17 inflammatory stress associated with the brief period in which your heart is deprived of oxygen in association with open heart surgery. So that concludes this section on nuclear factor kappa beta, ECP, my favorite therapy, and ACE inhibitors and ARBs, which amongst the drugs available are some of my favorite therapies. This completes disc 2, and now we'll go on to disc 3, where we're going to talk about milieu therapy, vitamin D and fish oils. We'll talk about immune modulation with testosterone. I'm going to talk about 2 other drugs, pentoxylene and famotidine, and then I'm going to summarize and construct for you a plan of action to increase Tregs and downregulate Th1 and Th17 to protect you from atherosclerosis and heart failure, and to stabilize or improve your atherosclerosis and heart failure if you have these conditions. Thank you for your attention.